Good morning, good afternoon, good evening to all the participants. My name is Tiki Pangestu. I'm the interim co-chair of the Asia Pacific Immunization Coalition. Welcome to this international conference on vaccine confidence and acceptance, which is being hosted by the Asia Pacific Immunization Coalition, by the Behavioral and Implementation Science Interventions Initiative based at the Yong School of Medicine at the National University of Singapore, and also by the Swee Hock School of Public Health. As you all are aware, this is a very important and timely topic for us to be discussing, and we have an exciting array of speakers to share their knowledge with you today. So please also feel free, later on you get an opportunity to ask questions. So it is now, without further ado, my honor and privilege to welcome Professor Tan Eng Chai, who is the president of the National University of Singapore, to deliver his welcome and opening remarks. Professor Tan, over to you.
Thank you, Tiki. Good morning, good afternoon, and good evening. Thank you for joining us virtually. A virtual format allows participants to join in whenever you may be, even as travel restrictions are in place, and the world continues to grapple with COVID-19. There are now new disease variants and new clusters and patterns of infections. The situation is ever unfolding. Today's international conference on vaccine confidence and acceptance is convened by the Asia Pacific Immunization Coalition and jointly hosted by the Yong School of Medicine and Swee Hock School of Public Health. In the words of WHO Director General, Dr. Tedros, every new, safe, and effective tool against COVID-19 is another step closer to controlling the pandemic. Approved vaccines are an important line of defense for the local community and for the world. Yet, vaccine hesitancy and uptake have remained a challenge in some societies. There's a need and urgency for stakeholders from grassroots to highest levels of decision making to come together to address this issue. In light of the ongoing increase in community clusters in Singapore, expansion of vaccination is critical to achieve some level of immunity and protection so that our lives and economies can regain some normalcy. The speed of vaccine development and rollout have been unprecedented, and we must acknowledge the good work of the scientific community, governments, and industry who have rallied together. Yet, it is precisely the speed, novelty, and plurality of vaccines that have given rise to heightened vaccine hesitancy among some segments of society, including healthcare workers. Understandably, there are questions and concerns among the public on safety and efficacy standards. There is also some hesitancy and misinformation about the value of vaccines. Comments such as they got vaccinated but they still got infected are spreading on social media and in the public domain. How do we make sense of this deluge of information on vaccines? We must be mindful that in this internet and digital era, one is prone to the echo chamber effect. People are receiving their news online more rapidly through social media platforms such as Facebook, Google, and Twitter, which have established personalized algorithms intended to cater specific information to individuals' online feeds. Much as we can use social media for education and rapid dissemination of information, equally, it is all too easy for fears and misinformation to be accentuated and perpetuated. In a country as diverse as Singapore, specific knowledge, data, and understanding about the different drivers of vaccine hesitancy among different groups is increasingly important, as it will help us to respond in a more effective and targeted way. With the speed of rumors and misinformation, overcoming vaccine hesitancy will require a coordinated, interdisciplinary strategy involving not only the health and medical professionals, but equally the social and behavioral scientists and communication specialists in close collaboration with the media and the community. In this regard, NUS recognizes the importance of interdisciplinary research and education, especially in fostering creativity and in developing new, comprehensive solutions to multifaceted problems. The new College of Humanities and Sciences, for example, is a new transformational educational model which offers an interdisciplinary, integrative, common curriculum and highly flexible pathways across the sciences and mathematics, humanities, and social sciences. The NUS approach emphasizes the ability to think, harness, and synthesize expertise, knowledge, and insights across disciplines. Such an approach is necessary in tackling complex challenges, such as implementing mass vaccination programs to combat COVID-19. Medical knowledge is one important aspect. Health economics, social psychology, epidemic modeling, material science, and an understanding of the political context are all highly essential and must work together to save lives in a pandemic. As a contribution to the effort, NUS has established the Asia Pacific Immunization Coalition, or APIC, within the School of Medicine, with the objective of tackling immunization resilience in Asia Pacific through a holistic approach. Resilience in vaccine delivery systems and increased confidence in vaccines are the bedrocks of future preparedness, not just for COVID-19, but for future pandemics. APIC takes a regional, collaborative perspective in bringing together interested stakeholders in the Asia Pacific to better prepare the region for future pandemics. Its evidence-informed approach to research, education, advocacy, communications, and policy outreach is pivotal in advancing a vision for the region where our people are protected from emerging diseases and are knowledgeable about the value of vaccines. This conference brings together a wide spectrum of participants, including researchers, policymakers, the media, civil society, and the general public, as well as patient and consumer groups. I'm hopeful that this platform will serve as a catalyst for collaboration and the exchange of best practices across the region. We are living in a globalized and interdependent world, and we can only overcome pandemics together. On this note, I wish the conference every success. Thank you.
Thank you very much, Professor Tan, for your insight on the challenges facing us, and importantly for your support in the terms of the convening of this conference. I would now like to invite Professor Chong Yap Seng, who Dean of the Yong Lulin School of Medicine, to deliver his remarks.
Thanks, Tiki. A very good day to NUS President Professor Tan Eng Chai, distinguished speakers, colleagues, ladies and gentlemen. Thank you for taking time to attend the International Conference on Vaccine Confidence and Acceptance, organized by the Asia Pacific Immunization Coalition and jointly hosted by the NUS Yong School of Medicine and Swee Hock School of Public Health. For more than a year, COVID-19 has been relentless in disrupting and claiming lives globally. India is currently buckling under the immense pressure of its second wave. Taiwan, which has consistently reported zero local transmissions since April last year, saw a jump in local cases starting in May, and their population has gone into voluntary quarantine until after tomorrow, when their level 3 alert is scheduled to be lifted, although that is now uncertain. Singapore has also seen new clusters forming and a drastic rise in community cases, which has forced the government to reintroduce stricter curbs in what we call phase 2 heightened alert to flatten the curve. Even as the COVID-19 virus rears its ugly head, the COVID-19 vaccine is proving to be a game changer in the pandemic fight in countries like the UK and the USA, where vaccinations have proceeded quickly and allowed many restrictions to begin to be lifted. Yet, there have been significant bumps and roadblocks in the global vaccine rollout. Some countries, such as Israel, have achieved high levels of vaccination, but many others face challenges accessing vaccines or have fallen behind in the vaccination plans. Slow vaccine rollouts mean that populations remain vulnerable to the severe manifestations and consequences of COVID-19, prolonging the trauma and devastating effects of this pandemic. It also means that the SARS coronavirus 2 will continue to mutate and spread and keep the world unsafe. Border closures, whether voluntary or forced, are never complete. And as long as unvaccinated and vulnerable populations exist, the world cannot be safe. COVID-19 has made this point painfully clear. For all we have done to achieve zero community cases in Singapore over the last year, it is discouraging for many to now have to get used again to the strict safe measurement measures of the phase 2 period. The majority of us have been adhering to the now familiar requirements of hand hygiene, wearing of face masks, social distancing, and safe entry. Nearly a third of the population of Singapore has received at least one dose of the vaccine to date, with our entire adult population expected to receive their first dose by early August. Though we still have some way to go, we are making progress, and we should not give in to fatigue and frustration and slacken our efforts to fight the virus. We are still learning new things about the virus, the disease it causes, and its response to the vaccines every day. Reports of vaccinated individuals developing blood clots after taking one of the vaccines has unnerved some and casts doubts on vaccine safety among the public. The recent news of the emergence of new mutants, more infectious than the original coronavirus, has also raised much concern. But this does not mean that the COVID-19 vaccines do not work. The false assumptions that the current vaccines are losing their effectiveness or were not effective in the first place have to be speedily corrected. Rumor mongering and the spread of misinformation is a clear and present danger. We need to constantly ensure that health authorities identify and counter misconceptions as they surface. This is not easy. It involves keeping one's ear to the ground and carefully and proactively addressing public concerns early with clear science-based evidence. Crucially, we must be able to meaningfully and empathetically engage the public. Such dialogue is important not only during the pandemic, but also beyond COVID-19. There's very good work that's already been done by many organizations, including the Vaccine Confidence Project led by Professor Heidi Larson, to inform the public about the benefits and safety of vaccinations against many harmful diseases. But more needs to be done, and this is a mission that we must all contribute to if we are to make the world a healthier and safer place for all. For those of us fortunate enough to have access to vaccines, taking it as a choice we are free to make. But we should be clear that choosing not to take a vaccine when we are able to is choosing to endanger others. To reflect our strong commitment in uplifting vaccine confidence, the Yong School of Medicine and the Swee Hock School of Public Health at the National University of Singapore have come together with the Asia Pacific Immunization Coalition to jointly organize today's international conference on vaccine confidence and acceptance. Through evidence-based research, we hope to contribute to global conversations to strengthen belief and conviction in current and future vaccines. There will be similar and perhaps even more deadly diseases after COVID-19. We need to ensure that all people, both young and old, understand the value of vaccines and their crucial role in creating healthier societies, with a clear understanding that no one is safe until everyone is safe. May you stay in good health and always get your vaccinations safely and on time. And I wish you a fruitful conference. Thank you.
Thank you very much, Professor Chong, for a masterful summary in 5 minutes of all the key issues and challenges that will be addressed by our speakers. It's now my pleasure to introduce Professor Y.Y. Teo, who is Dean of the Swee Hock School of Public Health at the NUS. Y.Y., over to you.
Thank you very much, Tiki. Good morning, good afternoon, and good evening to all the participants of this conference. It's a real pleasure for the Swee Hock School of Public Health to be jointly hosting this series of important discussions around vaccination as part of the Asia Pacific Immunization Coalition. A lot have been said by Professor Tan and Professor Chong, which I wouldn't repeat, but I think it's important to highlight that even before the start of the COVID-19 crisis, vaccine access and distribution have already faced uphill challenges and tasks centered around inequity and poor health literacy. We talk about fake news, misinformation, and disinformation, and those have actually worsened in light of COVID-19. Internationally, there has been a global framework, which is through Gavi, the Vaccine Alliance, to try and assure countries, particularly the low and middle income countries, of access to much needed vaccines, whether it is for human papillomavirus vaccines, the polio vaccine, and right now, when we talk about the COVID-19 vaccine as part of the COVAX facility. But many of these concerns that have been faced, that have plagued vaccine access, have been made much worse because of geopolitical tensions and local politics. There are many decisions made locally that have actually hindered access and the literacy and understanding of COVID-19 vaccine. Even right now, as we talk, the problems of vaccine diplomacy is unfolding real time in some countries in Asia and other parts of the world. When we think about the global vaccination situation that Professor Chong has highlighted, it is very clear that 75% right now of all the COVID-19 vaccines is really currently being accessed and utilized, distributed by 10 countries in the world. We heard from this week's World Health Assembly that there remains huge inequity, and particularly when there is a resurgence of cases in local jurisdiction, that countries now start to ring-fence further vaccines for their own people, to the extent that the COVAX facility, as of this point, is short of almost 200 million doses to meet its schedule of distribution to the necessary countries to even vaccinate the bare minimum of the healthcare workers and the elderly. We've heard from Professor Tan and Professor Chong about the outbreaks that the world, especially this part of the world, is facing, especially Taiwan, Thailand, Vietnam, Hong Kong. And I think it's important to realize that a lot of times when we start to talk about vaccines and vaccination, it is not just the challenges of access, but equally about what local governments have to do to build confidence, to build the vaccine distribution logistic pipeline in the community, to decide how to prioritize the distribution of a limited supply of vaccine doses, and most importantly, how do you communicate the benefits and the anticipated side effects to the people in a transparent but informative way. So today's conference is really aimed at addressing many of these issues, and we have been very privileged to bring together local and international experts in vaccinology, vaccine confidence, and in public health. And I hope that participants, you will enjoy this particular symposium and find it to be educational, and more importantly, take some of the lessons and reflect on it, and perhaps to advise your leaders in your respective countries on how to make use of some of the lessons shared today. Thank you once again for joining us, and over back to you, Tiki.
Thank you very much, YY, for your wonderful remarks that builds on Prof. Chong and Professor Tan. Okay, so at this point, it is my honor and my pleasure to hand over the proceedings to my, in a way, partner in crime, my interim co-chair for the APIC coalition, Heidi Larson, who is at the London School of Hygiene and Tropical Medicine. Over to you, Heidi.
Thanks, Tiki. And it's really an honor to be here at my cousin, and also I look forward to my affiliation with NUS. I'm thrilled with this attention to this topic, given my leading the Vaccine Confidence Project, and recognize this, as has been said, COVID has only brought this issue to the fore. I'll talk more about that and reflect on some of the key points by our opening speakers, which are all crucial as we move forward. Without any further ado, as they say, I'd like to introduce our panel speaker this morning. I'll just introduce one at a time as they present. First, Professor Benjamin Yong, the chairman of Singapore's COVID-19 Vaccination Strategy Committee, and also Senior Vice President, Health, Education, and Resources at NUS. Welcome and thank you.
Thank you, Heidi. Today I have the pleasure and honor of actually sharing our own journey as far as COVID-19 vaccination is concerned in Singapore. Can I have the next slide, please? When you look at the WHO SAGE definition, vaccine hesitancy refers to a delay in the acceptance or refusal of vaccination despite the availability of vaccination services. And this is a very complex and context-specific issue, varying across time, place, and vaccines. And there are 3 C's of factors that actually influence this: complacency, convenience, and confidence. I will actually cover these from our local context. Next slide, please. I will start with confidence, and I've paraphrased this as trust. I thought that this is the most important one that we have to address and establish first. The elements that I personally feel and my committee feel are actually important first is to look at the effectiveness and safety of the vaccines that we have. Then, of course, the system that delivers them, the reliability and the competence of the health services and the health professionals involved. And finally, the motivations of policymakers who decide on the needed vaccines. Next slide, please. I will talk first about safety and effectiveness because I think this was very important. And I wanted to add that to begin with, my committee and myself started with a blank slate. We were not under any undue pressure to be forced to actually say okay, essentially, to the vaccines that were available at that time. We looked at the dimensions of safety, which we felt were most important. Most importantly, the science behind the vaccine itself. We looked at how well conducted and how transparent the vaccine trials had been. And we looked at the reported adverse events that were encountered as the trials progressed. And the number of cases in various studies were then looked at, as well as the quality of manufacture, and subsequently the cold chain and consignment checks that needed to be brought into play. Here we were fortunate because of the expertise and quality and robustness of the evaluation by our Health Sciences Authority and the expert panel that independently also looked at it. They made their decisions autonomously, as did we. As a similar sort of parameter to safety, equally important parameter to safety, was the efficacy of the vaccines. We looked and studied the various stages of the vaccine trials, as well as the quality of the trials themselves. We looked at the outcomes, the choice of trial subjects, and how they potentially might apply to our local population. And then, of course, because we were following on in terms of our adoption, we had real-world information emerging for countries that had started and moved ahead faster in terms of their vaccination programs. Next slide. I thought that one of the biggest challenges we had was communicating across even the issues of safety and effectiveness. And while we could do this in a very scientific and medical way, we know that the easiest way to do this is to use language and graphics that are easily understood by laypersons and our general public. We also knew that we had to make this easily available. We had to utilize multiple available platforms, as these have actually grown over the time. And we needed to also structure and develop the program such that different segments of our population would be able to access them appropriately. In Singapore, we have 4 official languages, so we had to configure them for the different language media within Singapore and for the various segments of our population as well. Next slide. The other elements that are really important for trust are the competence and reliability of healthcare within Singapore and healthcare professionals by and large here. And here we're fortunate because our healthcare professionals are generally held in very high regard. In addition, I think our public also looks at the motivation of the government behind the vaccination program and our overall fight against COVID. And I think that's also an important element because trust in our government also remains key in our rollout. Next slide. Beyond those initial elements, we felt that convenience was very important. We had to remove barriers to access. We had to create physical availability. We had to make it affordable. And our vaccine program is free. To make these accessible, all our vaccinations were made available at a convenient time and place and in as comfortable a setting as possible. At each of these settings, communications and guidance was given to help people navigate through as well. And there was a service quality set for the way in which each vaccination center or each clinic would then be providing the vaccination for the public as they came up for vaccination as well. Next slide. To make it as convenient as possible, multiple vaccination centers were set up. And I know this map is rather small, but it is to basically highlight in all the dots where the vaccination centers are. And of course, our network of public health preparedness clinics were also involved, as all our polyclinics, as well as our hospitals for selected cases as well. I might add that in some ways, previous pandemic threats or epidemic threats did prepare us because it allowed us to exercise a mass vaccination program beforehand. Next slide. This is an example of a vaccination center. I just picked one, showing essentially the layout to ensure that the social distancing is actually adhered to and observed at that particular center as well. Next slide. And these are examples of some of the flyers and information that one can get from our Ministry of Health website that essentially give the necessary information and of course simple sort of flyers as well as graphics on vaccination, our vaccination program for COVID-19. And we've even set up a WhatsApp group to actually give information pertaining to COVID-19 earlier on, and we're able to leverage on this for the vaccination program. Next slide. I think it's very important, even as we share about the effectiveness of the vaccines that we've deployed, that we are also transparent about the potential effects or side effects. After we had accrued a sufficient number, the Health Sciences Authority went public essentially with our experience pertaining to the side effects that were felt by members of the public that had come forward. Overall, this demonstrated a very high level of safety and actually gave many members of the public, and I guess many of my healthcare professional colleagues, the confidence to continue to push ahead with it. So I feel that trusted information is really important to actually bring across to the public. Trusted early adopters, use of various media sources, independent experts weighing in, as well as the importance of transparency. So previous Minister of Health, Minister Gan, actually gave a parliamentary statement and shared the data in the correct context as well to help members of the public make the best decision they can. Next slide. So where are we today? And these are actually publicly available information and actually has been shared. We are very close, quickly closing in on about a third. And of course, it would be nice to actually be higher. And the bar chart on the left is rather small, but essentially you can see that there are some countries that have moved quite far ahead. Singapore is not far behind. And in many ways, because our non-pharmacological interventions have still been largely intact, that we're still quite all right at this particular point in time. In terms of the coverage, we have actually chosen also to cover those that are at greater risk, like healthcare workers, the elderly population, or frontline workers to begin with as well. And as has already been reported, in excess of 85% of our healthcare workers have been vaccinated, fully vaccinated. As far as our elderly are concerned, above the age of 70, over 60%, and over the age of 60, over 65% and counting, even as we roll out. And thankfully, so far, we have strong demand. Our speed is largely constrained by how fast we can bring the stocks into Singapore as well. If you look at the next chart, next slide, please. You can see that over time, as more people get vaccinated, the share of people willing to get vaccinated has also grown. There were some surveys that were done earlier in the year that seemed to suggest that Asia Pacific countries were very likely not to be keen to adopt vaccination. But I think over time, this has been proven not to necessarily be the case. Regardless, because we're still early in the vaccination program, this is not the time for us to rest on our laurels. We have to explain the issue of the occasional vaccine breakthroughs that we see. And we also have to be able to counter the misinformation epidemic that has been going on as well. Next slide. I think I wanted to spend just a little bit of time on helping the late adopters and doubters in adopting vaccination. Many of these believe they have little to gain from vaccination. Some may have concerns about immunization in general. Some, of course, question the value of taking the COVID-19 vaccine at present and will adopt a wait-and-see attitude. This, of course, has often been the case, particularly amongst countries that have done better in terms of containing the local COVID spread. Some have outright opposition to vaccines and government efforts, and many of their own social networks may just be echo chambers of very negative comments. The last one is actually quite difficult to combat. But if we believe that vaccination adoption is a little bit like the adoption of innovation, then what is quite important for us to do is to get over the hump and actually get the wait-and-see group to come on board and then just try to concentrate our efforts on the remaining after that. So what can we do to address the late adopters and the doubters? Next slide, please. Personally, I think that we need to persist with education. We have to start to use a lot more targeted influence in their own community or groups that they frequent. We need to persist with trusted experts. We may need to use religious leaders as well in a targeted sort of fashion. And we may need to be a lot more specific with comparisons and outcomes. The last bit I thought was interesting, and that is sometimes, particularly in the Singapore setting, the fear of missing out, there's a local term for it, is something that is also important, and we may not have harnessed it enough. For example, some would actually say that if I can travel, that's the one setting essentially when I would actually put up my hand and get myself vaccinated. We can see some of it now at work, even without any direct attempts to actually leverage on that. But I think going forward, there may be some ways in which we can nudge some individuals to do this. Individuals who want to travel overseas for studies, for example, may then feel that they would like the additional protection of being vaccinated. There may be some waivers of testing, for example, as it has been adopted in other overseas jurisdictions. And the CDC in the US, as well as Israel's green card, also some examples of how this has actually been done. Next slide, please. This is my second last slide. This is our Ministry of Health summary page, essentially to outline how we've been doing so far. It tells the public how many cases we've seen of late. It tells about the vaccination progress as well. And I think from my perspective, it is very important in this setting of a lot of misinformation that each country is as transparent with the data it has as is possible, giving to the members of the public and the healthcare professionals enough information for them to make the right decision. Next slide. Next slide, please. These are my closing thoughts. First, I feel we've reached a crucial stage in Singapore's war against COVID-19. We need a higher uptake and a faster uptake of vaccination if we are to gradually relax on some of our non-pharmacological interventions over time. At the same time, as has been shared earlier on, because of the emergence of variants of concern, we need to remain nimble as we learn how to deal with these new VOCs. We need to adapt our testing methodology. We need to recalibrate our approach overall, to deal with them as well. We need to be aware that around us, many countries still continue to struggle with outbreaks. And most importantly, we need to continue to build on the partnership with our people to overcome this challenge together. Thank you very much.
Thanks very much. That was really a fantastic presentation and really touched on some critical points that I'm sure will come up in different ways throughout our discussions. I will leap right into Professor Tambaya. Very happy to have you here at this important meeting. Professor Tambaya is a professor of medicine at NUS and a senior consultant ID physician at the National University Hospital. Thanks so much and look forward to your presentation.
Thank you very much, Annette. I'd like to thank the organizers for inviting me to do this talk. So again, one of my roles up to the end of last year was head of the Infectious Disease Research Coordination Unit at the National Center for Infectious Diseases. And one of the things that I did actually was to give out small grants. So we gave out a grant at the end of 2019 to one of the scientists, young scientists, who wanted to visit the Wuhan Institute of Virology. And she wrote to me at the beginning of January, and she said, there's a recent emerging virus burst in Wuhan spread over the whole of China. I'm afraid I have to cancel my February trip. I've managed to cancel my hotel and other bookings. However, the only flight from Singapore is on a budget airline, and they refuse to refund my ticket. Can I still get it reimbursed? So to my eternal shame, I wrote to her and I said, we should try to reimburse if she can only provide documentation. She was told not to go. If she's just scared of getting pneumonia, we should not reimburse her. And of course, the rest is history. We've had several 100 million people infected. We've had millions of deaths, and we've all learned our lessons. Now, I am actually an academic infectious disease physician. And when people ask me what that means, I tell them basically what it means is I spend most of my time looking after patients. But my promotion depends on my research output, and my bonus depends on the student evaluations. So this is a patient that I looked after, a 72-year-old man with hypertension. Like a lot of grandparents in Singapore, his duties involve picking up his grandson from tuition daily. He was vaccinated on the 2nd and 23rd of March. He showed up to us in May with mild fever and sore throat. He was tested, and because his grandson turned out to be positive, and he turned out to be part of the tuition center cluster. He recovered well. In fact, by the time I saw him on the second day of admission, he has no symptoms, and he's now at the resort recovering. We did his serology, and what you can see is that he was negative for the nucleocapsid antigen. He did not have actual disease, but he had a very strongly positive response to the spike protein, which is what you see with vaccination. So this is the kind of case that you've heard about. You get vaccinated and you still get sick. But he actually told me, he said, you know, I was so glad I got vaccinated because I'm 72 years old and all I got was a scratchy throat. So this is what we've been seeing. The other instance which I like to highlight is the so-called Tan Tock Seng cluster. This occurred in Ward 9D. And the first case to come to attention was a nurse who had been vaccinated, received 2 doses of vaccination, and she came down with upper respiratory symptoms. But this is an infographic done by the local media on the Tan Tock Seng cluster. And what you can see is that there are 8 staff and 1 cleaner altogether, a number of whom were vaccinated. On the other hand, there were 22 patients in that ward. Now, if any of you have ever been in a C-class ward in a Singapore public hospital, you realize that there are about 20 or 30 nurses. So if you only have 3 nurses who are infected, that gives you about, presumably all the nurses were vaccinated. So that's a vaccine efficacy rate of about 90%. But to put it in graphic terms, and you notice the graphics have improved over the years, 17 years ago, this was SARS in Tan Tock Seng. When the index patient appeared in the ward in Tan Tock Seng, you had 10 healthcare workers infected and only 2 patients infected. There was no vaccine available. No one was vaccinated against SARS. So the attack rate in a C-class ward, if we didn't have the vaccination, we'd have probably about 20 to 30 nurses infected. And that's an important point to bring across to people who are wondering about it. And there's, of course, peer-reviewed published data from overseas, from Qatar, showing the efficacy of the Pfizer-BioNTech vaccine against the B117, B1351 variants. And of course, Financial Times got advance notice of the efficacy of both the AstraZeneca and the Pfizer-BioNTech vaccines against the 1617 vaccine variants. I personally think that the immunity is going to last a really long time. And this is based on work done by colleagues at Duke and US, led by Professor Antonio Bertoletti, who have shown that the T-cell response in individuals persists over time. And in fact, they actually got individuals who had SARS 17 years ago, bled them, and found that they still had T-cell responses when they were stimulated with exposure to SARS-CoV-2. Just last night, the WHO had a discussion on immune correlates of protection for vaccines, and it was pointed out that with the Pfizer and Moderna vaccines, in the first few days after the vaccination, you don't have detectable antibody, but you do have protection from clinical disease, which picks off quite early after the onset of vaccination. So we can't really depend on antibody titers as an indicator of protection itself. Now, the interesting thing about this pandemic, and there'll be many, many interesting things about this pandemic, is that I think that skepticism has come from unusual quarters, in particular the so-called health experts or the 600 over epidemiologists who seemed concerned that the CDC was recommending that vaccinated individuals do not need to wear their masks. And, you know, the concern is that somebody who is vaccinated could still transmit the disease. So there was another presentation of a WHO guideline group last week. And I asked this question, has there ever been a documented transmission from a vaccinated individual? I asked this of the team from Public Health England. And Dr. Nandini Shetty said, we're still doing the sequencing, but we can't find anyone offhand. So to my knowledge, there has never been a transmission of COVID-19 from a vaccinated individual. So I think, you know, the epidemiologists need to look at the data a bit harder. Now that's the efficacy part, it's pretty good. The other issue is the safety, and that's what I've chosen to talk about a bit more today. So there's all these concerns about strokes, cardiovascular disease, and this is a call I received from a neurosurgeon. She said, I've got a young police officer with a very unusual stroke. He's a newly diagnosed hypertensive, but the bleeding is in an unusual place. So I immediately wrote to a good friend in the Health Sciences Authority, and she replied that they need to submit the reports. There are 2 different ways they can submit them, and they'll work them out. So this is the story. He's a 36-year-old policeman. He was a smoker. He's married with an 8-year-old child. He had undiagnosed hypertension, which was only just picked up. He was vaccinated on the 20th of February. A week later, he felt unwell at work and he was unable to walk. He was brought to hospital by ambulance and he became progressively drowsy. Now, for those of you who are not used to reading CT scans, this is the normal brain is on the black or gray side, and the white part is a large bleed, which goes into the ventricle or the middle part of the brain where the fluid is. And this was evacuated the day after his presentation. He was undergoing rehab, but he's still severely disabled. And to this day, we haven't quite figured out what was the cause. It could just be a hypertensive bleed. Now, the reason why this is a concern is because in July last year, while the epidemic was still raging in Singapore, there was a 72-year-old woman who was otherwise previously well, only mild diabetes, brought to a hospital by an ambulance, found to have an intracranial bleed, also in the back part of the brain, had a routine X-ray done by the emergency department, which was not typical for someone with a stroke or a bleed. So the ED doc called me at 2 a.m. and said, could we do a test for SARS-CoV-2? And at that time of the night, someone asks you something, you just say yes. So I said, go ahead. Then she said, what about the family? I said, well, are you this lady sounds like a pretty nasty bleed, so she's probably going to die. So let the family hang around, but tell them that they might be quarantined if she turns out positive. And I said, I don't think it's going to turn out positive. It turned out that she did turn out positive, and we didn't believe it. So we got some leftover blood. We did her serum, and true enough, she did have antibodies to SARS. So we tracked down the few family members who had been around, put them in quarantine, and there was no secondary spread. The case was reported in the local media. Interestingly enough, she wasn't classified as a COVID death. That's the way we classify it, which is why it's sometimes difficult to compare across countries. But this whole issue of central nervous system disease is something which has come up. And a group of neurologists from across Singapore has looked at young men who had asymptomatic COVID-19 disease, primarily the migrant workers during the big outbreak last year. And they've seen a number of them with acute ischemic stroke, which is a different kind of stroke from the bleed. And one of the fears is that this may be an immune overreaction. And a group from NCID, led by a group from NCID, again across the country, have shown that when you compare individuals without pneumonia, those with pneumonia without hypoxia, or those with severe pneumonia requiring oxygen, those with severe pneumonia requiring oxygen have higher level of antibodies and also have peaked their antibodies earlier with some of the cytokines involved. The one that has hit the news is the blood clots associated with the J&J and the AstraZeneca viral vector vaccines. And this is a report from JAMA. There was also one in the New England Journal of Medicine. But this was also reported with disease, not just with vaccination. So COVID-19, this is a group from Singapore General Hospital reporting cerebral venous thrombosis in a patient with mild COVID-19. Again, thought to be related to the immunopathogenesis of COVID-19 disease. But the European Medicines Agency reviewed the data and they came to the conclusion that the benefits still outweigh the risks despite the link. And these incidents are rare. They're very rare. We're talking here about, a few in a million. And just this morning, somebody in clinic asked me about blood clots because she had a bleeding disorder when she was a child. And I said to her, even if the incidence is 10 per million, that's 999,990 people who are going to get the vaccine and are not going to get a blood clot. So you've got to just weigh up the numbers. And it's not just AstraZeneca and Johnson & Johnson. In fact, this is a preprint which reviewed administrative database and they compared COVID-19 disease with influenza. And they found that the relative rate of incidence of cerebral vein thrombosis was much higher in those with COVID-19 disease compared with influenza. And mRNA vaccines had a slightly increased risk of cerebrovascular, this cerebral venous thrombosis, but nowhere near as high as COVID-19 disease. Now, to draw analogies with other vaccines. So the dengue vaccine, again, as most of you know, it's the first ever dengue vaccine after 60 years of research into dengue, was licensed after this paper was published in 2015. This is the CYD-TDV vaccine. And basically, it showed a pretty good efficacy. But when you broke down the age groups in the younger children, it did not seem to be that significant. So what the investigators did, to their credit, was they followed up these people over a period of time. So this publication in 2015, And in 2018, the 5-year follow-up data was published. And what it showed was there was a separation. So for those who were seropositive, there was a significant benefit in terms of, especially for the older kids, in terms of reducing the incidence of hospitalization and severe disease. However, for those who are seronegative younger children, that actually became, those who are vaccinated actually did worse than those who are unvaccinated. And this led to major changes in the labeling. So now the vaccine is only labeled for those who are seropositive for dengue. So this concern has been raised, whether there could be antibody-dependent enhancement. And it is too early to say whether this is the case. And hopefully, with the level of vaccination that's gone out, there will be no more COVID-19. So there's no chance of testing this hypothesis. Although the group from Duke NUS has shown that all the other coronavirus vaccines, almost all of them, have actually shown antibody-dependent enhancement in animal models, both small and large animals. So how did we deal with it in Singapore? The HSA is an incredibly professional agency, and they came up with a risk management plan, which has been detailed in the Singapore Medical Journal. And so basically, they came up with the idea that you need to show that you're seropositive before you can get the dengue vaccine. So the Pfizer authorization from the FDA also specifies that there needs to be follow-up over a period of time, because they gave the approval as an emergency authorization on the basis of a few months of data. And one of the things that they've done in the United States is open access to VAERS data. You can go to the CDC website, you can just key in what you want to look for, and you can find out the vaccine adverse event information. HSA in Singapore, again, has really good adverse event reporting. In fact, Singapore is amongst the highest rates of vaccine adverse events reported in the world. And that's not because we're prone to these adverse events, but it's just that the reporting is so good. And I don't want to take any credit for it. It doesn't come from the doctors. It mainly comes from the pharmacists. So the most commonly reported vaccine adverse events, this is just based on their report, came out May 2021, was things such as Kawasaki disease, primarily from MMR, also from varicella, 5-in-1 vaccines, thrombocytopenia, and others. So they are being captured. And as Prof. Ong has pointed out, these are being reported on the MOH website, so you can find out about them. One of them, which is particularly intriguing, is Bell's palsy, which was reported as 3.4 per 100,000 persons per month, which is about twice the rate that if you go to Health Hub, you'll find as the incidence in Singapore. Now, one of the things that comes up is this issue of scientists differing. And I think, this is where we are slightly different from the one message idea. And two of the clinician scientists I respect the most are Richard Wenzel, who started the International Society of Infectious Disease, and Fred Hayden, who mentored me in my journey in influenza. And some of you will remember in 2001, when they had the bioterrorism attacks, there was this massive campaign to vaccinate healthcare workers across the United States against smallpox. So Wenzel argued that it was dangerous and hazardous, and that you could wait until the first case occurred anywhere in the world, because smallpox hadn't been seen since 1978. On the other hand, Fred Hayden argued, he said the risk is extremely low, not zero, but low. He said the vaccine may be fatal to 1 or 2 people in a million. But he was so concerned that they were so near to GC that he insisted that they should go ahead and get vaccinated. So in Virginia, we had 2 teaching hospitals with opposite points of view. And this is not new in the vaccine world. Again, many of us know Salk and Sabin hated each other, and they had opposite views on how to get rid of polio. So Singapore was actually involved in the Sabin polio vaccine studies in the 1950s when we had these big outbreaks. And this is Kallang Airport, and children and parents just lining up to bring their children to get vaccinated, to take part in these studies, which actually established the role, interestingly enough, of Sabin type 2 during a Sabin type 1 outbreak and the cross-protection. So vaccines have stopped epidemics in the past, despite these differences between the scientists. But ultimately, vaccination choices are difficult, and they have to be made by individuals. This is Dr. Tam Wai Jia. She's with the medical school, and she's an amazingly open person. She talks about the struggles she's been through, and this is a unique one, where her husband is actually a liver transplant recipient, and they lived in Africa for a while, and they were required to take the yellow fever vaccine, or they wouldn't be allowed in the country. But as a liver transplant recipient, he couldn't get the yellow fever vaccine. So it's a huge dilemma. She's very religious, and she felt that this was her calling. And she managed to get the analyst who actually wrote the yellow fever guidelines to write him a waiver letter so that he could get into the country, take the risk of yellow fever, and go and do the work he felt called to do. So finally, there are these vaccine adverse events, but they need to be carefully analyzed. And the one that comes to mind is the last respiratory virus pandemic of 2009, where some of you know that one of the vaccines, Pandemrix, was actually associated with narcolepsy. The interesting thing is the two other vaccines that were specific to H1N1 2009 were not. So it was only that one particular vaccine. Another vaccine which used the same adjuvant but a different preparation was not associated with narcolepsy. And this, again, is a reassuring thing about this pandemic. We're going to have 20 or 30 vaccines to choose, and the ones that work are going to come through. But more striking is when they analyzed the data, they found that there was a strong association with HLA-DQB1-0602. And this is precision medicine, the kind of field that Singapore and the university are going into. So, when you're talking about 10 in a million, this is a really rare side effect. It would be really nice if we could know who was going to get the side effect and then prevent it. So in summary, I was vaccinated against the Pfizer-BioNTech, and the reality is I was vaccinated because I like to travel. This is me with the Mongolian CDC director next to Genghis Khan in a minus 70 degrees winter. I'm a healthcare worker. I feel I have a responsibility to my patients. And basically, I want the pandemic to end. I don't think we can continue with this two-person visiting rule forever. This is Changi Airport a few months ago, and I went to see off my sister. Thank you again. And if you have any further questions, you can email me.
Thanks very much. And that was a really important and other perspective, also putting the issue of risk in context, the importance of transparency, which we heard in the previous presentation, but also putting it in context. I'll move to our last speaker for the panel, this panel, Dr. Ruben Ng. Dr. Ng is the lead scientist on data and technology at the LFR Institute for Public Understanding of Risk at NUS.
Good afternoon, everyone. Thank you so much, Heidi, for that generous introduction. My name is Ruben Ng. I'm from the Lee Kuan Yew School of Public Policy as well as the Institute for the Public Understanding of Risk. My surname NG has no vowel, so sometimes, when I spend some time in the UK and the US, people just think NG because they cannot pronounce it. It's an abbreviation for no good. But I told them, no, it's not no good. It's nice guy. So I'm going to share with you today on vaccine sentiments and narratives across 20 countries. This is ongoing work, so I'm going to share with you some preliminary findings. Okay, just a quick overview of what I will run through today. First is the size of global vaccine conversations from June 19 all the way to January 2021. So we wanted to look at pre-COVID all the way to January 2021 this year. The second, besides looking at the size of global vaccine conversations, I will run through some findings about the global sentiments of vaccine-related conversations. Are people becoming more positive or less positive about vaccinations? Finally, I'll look at, besides sentiments, I'll run through some analysis on the shift in vaccine narratives from pre-COVID June 2019, month on month, all the way to January 2021. So before we go into the results, I just wanted to share with you the platform that we are using. This platform that we have created consists of 12 billion words. This is accumulated from online newspapers and magazines, from over 13 million articles. Because it's a dynamic platform, the data grow every week. So I think we are pushing almost 13 billion words now, taken from over 35 million articles across 7,000 websites. These websites consist of online newspapers, magazines, chats, blogs, and so on, across 20 countries over 10 years. As mentioned, this is a dynamic platform, so 40 to 70 million new words are added weekly, so it grows. And this is the biggest known cross-cultural corpus globally. This is the distribution of countries in our database. We have several countries from Asia, 5 from Africa, from US and Canada, Australia, New Zealand, as well as UK, Ireland, and Jamaica. These are only English sources. We do not have non-English sources within this corpus. So just a quick one about the methodology. These are the target words that we have chosen and we used for the search. First would be vaccination, vaccine and vaccines, immunize, both American and British spelling, immunization, and inoculate. So these are the target words. Then we also compiled the collocates of these target words. So for each of these target words, we compiled the collocates. So collocates, let me explain, are words that co-occur most often with the target words. Okay, but we use the more stringent methodology that would include, besides frequency of co-occurrence, we call them collocates, it must pass through two inclusion criteria. The first inclusion criteria is lexical proximity. So if we say hope is a collocate of vaccination, then hope must occur 6 words before, 6 words after vaccination, and not 2-3 paragraphs later. Okay, so that it's relevant. That's lexical proximity. If the word vaccination occurs at the start of the sentence, right after a full stop or period, the 6 words before are not included because they may refer to something else in a different sentence. The other inclusion criteria is semantic bonding. So semantic bonding is a concept in computational linguistics measured by mutual information score. Essentially what it means is that if hope is a collocate of vaccine, then hope must occur more times with vaccine than hope with something else. Okay, so we have a formula that we created and adapted called mutual information score. If you're interested, happy to send you some published articles about the formula and calculations, but essentially measures semantic bonding. So for a collocate to make it as a descriptor of each of these target words that we will compile at the end of the day, it must pass through 3 inclusion criteria. First of all, frequency. Second, lexical proximity. And third, there must be semantic bonding. So this rigorous process distilled over 70,000 vaccine-related collocates from June 2019 to January 2021 across 20 countries, of which we would analyze for 3 things. The first is the size of conversations, the size of vaccine conversations over time since June 2019. Then we will look at sentiments. So sentiments, each of these 70,000 collocates will be rated on a scale from 1 to 5, 1 being negative, 1 being very negative, 5 being very positive. They'll be rated by 2 raters from 1 to 5 to achieve inter-rater reliability. And then we will run some analysis on the content of the negative or positive stereotypes of vaccines. We call that narratives. I'll show that findings to you later. So the first insight we got, if you look at the graph here, we found an exponential growth of vaccine conversations from pre-COVID 2019. So the x-axis here is by the month. So we did this analysis month on month from June 2019 all the way to January 2021. And you can see initially, this is pretty much the baseline, and then it really shot up exponentially, the volume of conversations. And the y-axis here is words per million. So I used to have an epidemiology and biostats background. So when I applied that to studying words, I thought that we needed to come up with a prevalence. We needed a way to normalize the number of terms. Because if we use the absolute frequency of terms, it's not the best because sometimes the corpus size could be different month on month. So we normalized it and came up with this unit called words per million. So after the normalization, we found an exponential increase, not surprisingly. Okay. But what's interesting is the next chart I'm going to show you when we compare the size of growth of vaccine conversations against COVID-19 conversations, okay, as well as the incidence of COVID cases. So let me take you through. X-axis here is month, right, from June 2019 all the way to January 2021. The axis here on the left side will be words per million. So the words per million are related to the COVID keywords per million. So as you can see, COVID keywords have really spiked, but they are sort of on the decline, especially virus-related conversations about COVID. On the other hand, vaccine-related keywords, vaccine-related conversations are sort of taking over, right? Increasing. While COVID-related, virus-related COVID conversations are decreasing, vaccine-related conversations are increasing. The blue line here, we sort of overlaid it with incidence of COVID cases across the 20 countries month on month, and this is represented by the other y-axis here on the right side. And now we'll move on to sentiments. How do people across the 20 countries, narratives, right, when vaccines are being talked about, are they talked about positively or negatively? So this is the macro chart here again. X-axis is from June 2019 all the way to January 2021. Y-axis is the vaccine sentiment score. So higher up the y-axis means more positive, right? It's a scale of 1 to 5, 3 being neutral. So as you can see here, this trend is significant. So globally, narratives of vaccine conversations seem to be more positive over time. The next compares across different regions. So what we found was interesting was that at the baseline at June 2019, this was before COVID came into public consciousness, Asia was actually the most negative, or rather the least positive about vaccination. Africa Oceania was actually the most positive. But throughout COVID, from pre-COVID all the way to January 2021, as you can see here, Asia really has, the trend of vaccine narratives has really become more positive. And at the point of January 2021, the end of our study, Asia has actually become the most positive about vaccinations compared to the other regions. So we found that to be quite interesting, and that trend is also significant. So from size of conversations, from sentiments, we move now to what exactly are the conversations, what exactly are the topics that are prevalent in the different regions for COVID. For this, we did a more global, sort of across 20 countries. This is what we found. You just pay attention to the top, local political leadership is something I'll explain later. So from a pre-COVID perspective, we found that one of the key topics about vaccination is on global healthcare concerns. And when we talk about global healthcare concerns, there is a whole host of diseases of which there are vaccines for, okay? But now that it's not post-COVID, but it's during COVID at this point, actually the global health concerns for vaccine conversations have converged, okay? To coronavirus pandemic, emergency, polio, measles, and flu. What this means is that other equally important diseases such as HPV, dengue, and malaria have somehow fell off the media radar when it comes to vaccinations. So which means that they do not get as much emphasis now, and that's something we need to work on. We need to bring back the conversations, the awareness about vaccines related to HPV, dengue, and malaria that were prevalent before COVID, but now it seems to have fallen off the media radar. The other thing I wanted to highlight was the rest doesn't have much differences. So there's, of course, one topic pre-COVID on widespread vaccination. During COVID now, I wish it was post-COVID, but it's not. Widespread vaccination for COVID-19 related to that. But when it comes to efficacy concerns, it's really interesting because pre-COVID, June 2019 all the way to December 2019, when we talk about efficacy concerns, there was about a lot of safety, misinformation. Sometimes we saw autism coming up, linking it with vaccines. So it was predominantly neutral to negative. But now, during COVID, there are actually a lot of terms that are positive, such as hope, protect, prevention, cure, secure, better, achieve, and fight. So we seem to be riding a positive wave now on hope. Vaccinations as a whole tied to COVID-19, and I think that's positive. And when it comes to R&D, there were very generic words pre-COVID, but now during COVID, you see very specific words like Pfizer, antibody, mRNA, very related to the COVID-19 vaccination. And these are the two topics that came up for vaccinations during COVID, but never appeared pre-COVID. And one of the topics was on global vaccine production. There are a lot of conversations and narratives now about global vaccine production, especially the limitations and the lack of vaccination and the need to explore alternatives. So as we know, vaccinations, most of them is done through an injection. Perhaps there could be alternatives. There's a lot of talk now about alternatives. oral administration of vaccinations or maybe even a nasal spray. And one topic that never came up on vaccinations is the importance of local political leadership. Okay, President, Minister. In the past, if there was any leadership that came up, it would have been multilateral organizations such as WHO and so on. But now it seems that the dominant topic really is on local political leadership. So to summarize very quickly, these are some of the highlights of our initial and preliminary analysis. First of all, there's really an exponential growth in vaccine conversations from pre-COVID to now and during COVID. These vaccine conversations have surpassed virus-related conversations of COVID-19. Second, and very heartening as a public health professional, that global sentiments of vaccines have indeed become more positive, and Asia's vaccine sentiment seems to have improved by the largest margin. In fact, right now in January 2021, Asia is the most positive. Africa is actually the least positive. Okay, and there are key shifts in narratives, as I mentioned. Many global concerns seem to have sort of fallen off the radar a little bit. I think as public health professionals, we need to try to drum up the conversations again, because even though COVID-19 is raging, these are equally important, but they seem to have fallen off the radar, such as HPV, dengue, and hepatitis vaccines. And for the first time now, COVID-related, there are a lot of positive narratives associated with vaccine. All right, pre-COVID, there was stuff about misinformation, autism, but now that seems to have sort of evaporated, and a lot of conversations now about hope, and there's a prevention agenda. And vaccine productions, limitations, and the need to explore different alternatives. And of course, the importance of local political leadership rather than the global healthcare organizations that we have seen pre-COVID. So I think we are at an inflection point where I think there are a lot of opportunities to shape the vaccine narratives permanently for the long term. Right now, if we explore the trend of vaccine conversations over 2 years, this is one of the first times there are a lot of hope related words in relation to vaccine, and then there is that prevention agenda that didn't quite come up at the baseline pre-COVID. So I think therein lies an opportunity for us to make these narratives a little bit more permanent, so that from the long-term perspective, I think it raises the profile of vaccinations, not just for COVID-19, but for a lot of other conditions. With that, thank you very much.
Thanks very much. That was really fascinating, and also we do a lot of the vaccine sentiment analysis in the Vaccine Confidence Project, and I can see a number of areas of convergence. So look forward to following up with you on that. In the interest of time, I'm sorry to say I think we're going to have to cut short and not have the Q&A to move ahead, if that's what I understand, because I don't think we don't want to compromise the next panels and the rest. Tiki, is that correct? Just to...
Yes, that's correct, because we do still have a bit to go through. But I've checked with most of the panelists. We will collate and group all the questions and forward it to the panelists, and hopefully they will be able to respond. Sorry about that.
We didn't want to cut any of these excellent panelists short, so compromised on the questions there. But thank you very much. This was really an excellent mix of perspectives to set the stage for the further discussions and work ahead. Thanks so much. And I'll turn over to Tiki for the next session.
Yes, thank you very much, Heidi. And just let me add that we have received many excellent questions that picked up on some of the key issues. And we'll certainly do our best to put them all together and forward them to the panelists, hopefully to be able to then get back to the people who asked the questions. So let me now move on to the second part of the conference. It's my pleasure to introduce Scott Wong, who is a medical officer and senior data analyst at the Ministry of Health in Singapore. And Scott's going to talk to us about some exciting work he's doing which revolves around technology enablers to increase vaccine confidence. Over to you, Scott.
Yeah, thanks, Prof. Tiki, and hello, everyone. And I just be talking about all the technology enablers. And currently, I am a medical officer, so I do see patients on the ground every day. And actually, I also do a lot of digital health development work at the same time, mostly in the mobile application space. And a lot of times, I was also involved in both A*STAR and the Ministry of Health to think about how these digital technologies can actually, contribute to chronic diseases. However, during the COVID-19 pandemic, I was also on the ground where we had to face a lot of issues with regards to like language and literacy, really poor conditions to roll out many of these technological enablers in a pandemic condition in the entire country. So I thought maybe I can start with some take-home messages and some of my experiences while we are developing technology to fight vaccine confidence, to help with the vaccine confidence. And 3 take-home messages. The first one being that, we should always seek to empower the lowest common denominator because it's one of the most practical things to consider when trying to solve something that affects an entire population or even affects international populations. Secondly, as much as I would love to focus on technology, we should always be people first and technology second, because technology is meant to serve the needs of the people, especially those who are on the ground. And the third one is that, in line with what a lot of great themes today, is that technology really enables collaborations beyond healthcare. And it's not just about how we as healthcare stakeholders combat the disease, but it is a health problem and everyone really has to be involved to combat it. And when I was actually thinking about how best to display the message, and this is something that I drew up yesterday night, and that's a Facebook analytic page that actually also focuses not only the words but also a lot of the videos. And it's quite interesting that there are definitely good things going on social media. Like the WHO has its own page with about 20,000 views. And however, there are also a lot of things like vaccine misinformation that's actually happening live. And I thought just to show everybody how some of the things can spread. On the 21st of May, the WHO actually showed that the vaccine trials were quite safe. They had an infographic with 3,000 likes and I thought about 1,000 shares. On the same day, social media actually had a post of a talk show where some lady was able to get 67,000 likes and 30,000 shares on the reasons why she didn't want vaccines. So it's not just that there's mentions, but the number of shares that go offline that we can't trace is actually quite high. And even then, it's actually very true. The over-politicization of vaccinations, where this is New Delhi TV, just yesterday night says that vaccines in India have become a tool for the Prime Minister's personal publicity. So instead of saying, we know that vaccines and all these problems can be amplified, but how do we use technology to amplify our solutions instead? So while thinking about it, one of the things I thought was that we should use technology and try to aim for the lowest common denominators, because oftentimes, if you want to boost vaccine confidence, we need solutions that can be deployed almost countrywide in 24 hours, right? And can our vaccines be actually used? Can these technologies be used by most people, all the way from people who are, living in high-class areas, all the way to the slums? And can even be adopted in a few steps as possible. So what we found at least when I was on the ground in the COVID-19, was that just by thinking about the lowest common denominators, we really try to increase execution chances when you're even tackling vaccine confidence in the micro-worker dormitories, be it in a shopping mall, even in the slums in one of the many islands in Indonesia. So these are the first things that we have to think about. And just to go through like some specifics of how commercial entities do tackle other things like even ride-hailing services or even advertising, I thought maybe we can focus on how other commercial entities get proof of value in the field in most of Asia. One such example actually is things like progressive web applications, where in the last maybe 5 or 7 years, companies actually start delivering app-like experiences through web browsers rather than developing native apps. And many of these web pages now are so advanced that you can't differentiate the web page from an app. In fact, in Singapore, one of the major ways we were able to scale this was that instead of going to an app store, we just need to download a QR code, stick it on the wall, and many people, even when we are checking into a shopping mall, can just scan a QR code and access your information. And unlike in the past where web pages needed to be connected to a server, many advances nowadays allow things like service workers, which are mini servers, to be mounted on phones, such that even if a person who is in Indonesia and goes back, from Jakarta back home to, one of the countrysides, they are still able to get messages on vaccination, on even telling them where's the next vaccination and that vaccinations are safe, even without internet connection. So these things are just are already possible now. And instead of going through a long list of, where technology is in 2021, like lower production costs or lower file sizes, maybe it's better to go through how commercial entities like Uber and ride-hailing for Asia was a big problem back in the day. And they actually developed a 50 kilobyte app meant for 2G conditions to enable ride-hailing in other areas. Or how about even our own Changi Airport that has 68 million passengers? I mean, not last year, but the year before. But how do they make sure that the message or Wi-Fi connectivity is possible for all the passengers? They use a progressive web app. And even Starbucks, right? Commercial entities like Starbucks have managed to reduce 150 megabyte app to 240 kilobytes, such that every single store, no matter where they are, you can actually order a latte. So there's a lot of things that we can draw inspiration of from the commercial sector when we are considering, like how do we actually fight vaccine confidence on the ground? And certainly there are many other examples that I can go through today. But things like QR codes, social media analytics, and what even Dr. Ruben was doing, these things are actually, enabled by technology in recent years. But certainly the main message is that technology is really a great enabler, particularly from an operational efficiency standpoint, to tackle vaccine confidence issues all the way at the ground. However, instead of just talking endlessly about different types of technologies which will change, like next year it will be something else or 10 years later, one of the things I thought was useful was to go through, can technology really obtain efficiency rather than just be an enabler? And even in the course of the fight against COVID, I found that many people who think of technology may be biased towards solutionism or reductionism, where you try to say, hey, there's a technology and let me force something on the ground to try and solve vaccine hesitancy. Or maybe we just overgeneralize and simplify the problem, and therefore we claim that any technology can work on the ground. And the easiest way of doing it was that at the height of COVID, there were many chatbots being deployed in the dormitories, but sometimes for illiterate workers, that may not be the best thing. Whereas if the chatbot actually contained more audio and pictures, it just gave the message, greater understandability for many of the illiterate workers. And certainly some people, there's definitely a role for traditional surveys and things like that. But sometimes if we wanted to tackle really ground, volatile myths, maybe a long survey over a longer period of time may not be as accurate a way. And we may need to combine, certain other methods to have the granularity over time. And one of the things that I thought was useful was to actually just start from the people themselves. And if we are talking about vaccine confidence, it is always useful to know our target population. And different populations really need different messages and need different, interventions. For example, at the height of COVID in Singapore, where a lot of the migrant workers actually had COVID, we had to craft messages that were simple for 75% male population aged between 25 to 45 with great illiteracy. So instead of saying, let's craft a better form, why don't we use user interfaces that are already optimized for that population, right? I mean, if a dating website is already built for that, can we draw inspiration from other technological platforms? And by refining the technology to suit the people, we then increase the usability, such that by drawing what works in other technological platforms like Tinder and adjusting it such that it has audio, visuals, can we really make our technology usable by the people on the ground? But lastly, I think the most important thing is that vaccine hesitancy really requires a lot of collaboration beyond healthcare. And from what Singapore has experienced last year, it really is something that requires inter-organizational, inter-ministry, and international collaboration, both between the public and private spaces. And just to give you a few examples of how things can go really wrong. And at the height of COVID, many organizations, imagine if everybody had a separate app or even had a different data definition of what vaccine confidence really mean. Wouldn't our problems scale exponentially rather than the solution, right? But conversely, can we even as healthcare professionals even collaborate with things like social media to boost vaccine confidence? In fact, Facebook actually, for everything that's labeled to be related to vaccines, right? Actually, it labels a link below that even pushes people to see the legitimate sources. And can we even use, other things? For example, are we able to even have targeted ads? So this is something that I'm designing now. In a 15-minute wait time, can we even display certain things in different languages, not just to ask people about vaccine confidence, but in this case, MindLine is a tool that we want to ask migrant workers about whether they are, depressed or not. Can we use the same technologies to have targeted messages? So hopefully, can we fight virus with viral? Is one way that we can keep asking ourselves in this fight. And hopefully, I know it's a very short presentation, but the 3 take-home messages, I hope they are quite evident. And we have to empower the lowest common denominator, really put people first, rather than be a technological first perspective. And hopefully we have more collaboration through technology, where health is much more than healthcare. And thanks very much.
Thank you very much, Scott, for that very exciting work on the COVID buddy. And just to inform you, APIC is trying to facilitate some collaboration between Scott and some organizations in Indonesia, where obviously at the moment there's a great need for apps like what Scott has developed with the COVID buddy. Okay, we now I'm very excited about the next presentation because we're going to hopefully hear from the perspective of the public, the consumers, okay, and it's a real pleasure to welcome Karen Villanueva from the Philippines. She is president of the Philippine Alliance of Patient Organizations, as well as being involved in the International Alliance of Patients Organization. Karen, over to you.
Thank you so much, Professor Tiki, and I'm so pleased that the patient perspective is included in this very important discussion. So next slide, please. So I'll just briefly share with you a little bit about patient engagement and why it's important to engage the public, and some of the nuanced changes towards patient engagement. Next slide. So IAPO, or the International Alliance of Patient Organizations, was formed in 1999. And at that time, the patient voice and our participation and engagement in healthcare policy and decision-making were practically unheard of. We faced a lot of pushback from the state, from healthcare providers, health professionals, and even the pharmaceutical industry at the time. And over time, the value of patient participation and engagement in healthcare policy and decision-making was established through sustained advocacy and development of many capacities. We were able to earn the privilege to sit with some of the policy elites at the WHO, and we actually have a non-state actor status, and in other key healthcare bodies. And we did this by building the capacity of our patient leaders. Next slide, please. So today, fast forward, we feel that the patient movement has really come of age. And patient voices are now valued because we bring unique perspectives, our experience, and real life experiences in healthcare. And we have a voice that reaches out to key healthcare decision makers. And because health is a political choice, then the patient voice can certainly impact policy. So for instance, in my country, where I also sit as board member of the Philippine Alliance of Patient Organizations, we sit in various technical working groups, councils, and coalitions. But really, across Asia Pacific, there still needs to be more work in terms of increasing the patient voice. And 2 years ago, we have started the Asia Pacific Patients Congress. And we hope to be able to reach a level of patient engagement similar, for instance, in Europe, where patients are involved in clinical trials and they're able to sit in patient and consumer working parties at the EMEA. And at the UK, the patient experts are able to address national HTA bodies. Only because health and the economy are intertwined, and health is a political choice, and the patient voice can certainly impact policy. Next slide, please. So there's really no doubt that most of us know the importance of engaging the public in terms of vaccine research, especially now that there's a lot of fake news and anti-science information easily accessible to the public and very easily shared. And it makes you wonder why intelligent people do have the gall to share all this information, which really contributes to the infodemic, because if they have the trust of certain people, even their families, then there's a tendency to believe that person and share it again. So it's important that the public does not just include patient groups who have a heightened insight into vaccine development, but all other stakeholders, as mentioned earlier, such as the media, religious and educational institutions, and including marginalized segments of the population where health literacy is low. And the value then of involving patients in the research process is that this provides valuable insight, perspective, which can result in better treatments. It can also boost the safety and efficacy of new treatments, which can boost the confidence of the public. So for instance, when vaccine manufacturers were doing their phase 3 trials for the vaccines, there were TV interviews and articles quoting the experiences of clinical trial subjects. And those were really helpful and informative. And at the highest level, and in terms of policy making, engaging patients will improve and sharpen policies and ensure they reflect the needs and preferences of patients. Next slide, please. So we need to engage the public across the entire life cycle of vaccines, from research and development up to the regulation and licensing, in the program implementation and rollout, including monitoring. Next slide, please. So what are some of the changed approaches to engagement? I think we need to have a conversation with people and the community and really address their fears and concerns. So here at PAPO, we've started a series of webinars addressing the infodemic and vaccine hesitancy. And we're doing it per patient group, per disease category, because there are very specific fears and concerns. And we really want to hear what they're saying. And actually, the questions are almost the same every time. But it's important to listen and to assure them that we are listening. And we need to, when we engage the public, we need to move away from the approach of, I'm the medical expert, therefore you listen to me. And we need to come up with more compelling messages and really sort of appeal to the emotional side. And we've also, at PAPO, we've also crafted infodemic and awareness campaign for vaccination. And we're trying to appeal to a specific quality of the Filipinos, which is wit and humor. So we want it not to inculcate fear or reinforce fear, but we want it to connect with the people. We want to speak their language, so to speak. And as important as what we say is who says the messages. And we need to look at trusted influencers. Very important are frontline health workers, including those beyond public health. And very important is co-designing some of the strategies and some of the communications with the community. Next slide, please. So rather than telling people what we think they need to hear, we need instead to work directly with people, to listen to their concerns and work together to address them. And this is a better way to engage the public when planning, to implement and consult and communicate around important health topics. Indeed, such consultation approaches could have far-reaching implications beyond the health agenda and serve to better engage the public with policymakers and vice versa. So the operative word is co-creation, and it's really, as this APIC reflects, it's really a group of very diverse people with different talents and disciplines coming together to find solutions to a common challenge, which is vaccine hesitancy. So next slide, and this is my AYAPO battle cry. It's nothing about us without us. Let's work on creating an enabling environment to provide a platform for the patient voice and clear a space for patient engagement in global, regional, and national health agendas. Thank you very much. Over to you, Professor Tiki.
Thank you very much, Karen, for I think a very important contribution and for highlighting the importance of bringing the community, the patients, the consumers into the conversation. I think from my own personal perspective, I've sort of had the impression that, in the excitement of the scientific advances in implementation and efficacy and safety, we didn't often hear about how the community and the patients were actually involved, especially in the formulation of some of the policies, because at the end of the day, public health policies affect the people. So thank you so much for, I think, certainly I learned a lot from your presentation. Okay, so hopefully we'll get back to you during the roundtable, but let me move on now. It's a great pleasure to introduce my interim co-chair in the Asia Pacific Immunization Coalition. Heidi Larsen doesn't need an introduction. She's been a real global leader in this entire field of vaccine confidence, having led the Vaccine Confidence Project out of the London School of Hygiene Tropical Medicine, but also being a visiting professor here at the NUS. So Heidi, over to you.
Okay, great. It was a rather big title here, but I'll do my best. I think we've covered a tremendous amount of important work, so it's helped my presentation here. I'll just give you a 1 minute introduction to the Vaccine Confidence Project, which I founded 11 years ago, with the idea that we should be having our radar out and anticipating issues, trying to pick up early signals and acting early. Initially, it was like global online media monitoring because we didn't have the ubiquitousness of social media 11 years ago. And we've increasingly engaged around social media, recognizing that social media, you cannot rely on one data source alone. You don't get the representativeness in social media as you do with surveys where you have a lot of background data on the individuals. So we try to do a mix of both online surveys, person to person, and launched a Vaccine Confidence Index, which we've been running globally for 6 years now, and recently published a global mapping over time. on these issues of confidence. We did hear actually at the start of the day about the importance of confidence in terms of effectiveness and safety. And one thing that we've learned in the Vaccine Confidence Project, we look at the domains of confidence in the importance of vaccine, confidence in the safety, the efficacy, and is it compatible with my religious beliefs? And each of those domains give us different results. So a generic question about are you confident doesn't distill it into those streams. And the one that is consistently the lowest in confidence is safety. Importance is generally the highest, which is a good thing about importance. Between the 2015 launch of our index and which was published, by the way, the 2015 initial study was published in collaboration with colleagues at NUS. The recent 6-year analysis showed that the 2 countries in the world out of 149 that had the biggest drops in confidence were Indonesia and the Philippines. And in Indonesia, it was related to, I'm sure, being in the region. The world was aware of this, but particularly in the region, saw that there was a resistance, particularly among some Islamic leaders in Indonesia, calling the very age-old measles, mumps, rubella vaccine haram and not compatible with religious beliefs. It did create a lot of anxiety and resistance. But the important thing about in both Indonesia and the Philippines, both had specific vaccine confidence crises, which had a knock-on effect across vaccine confidence more broadly, which is a huge thing to remember for us in the context of COVID. This will be remembered, and how we manage vaccine confidence with COVID will be determine confidence more broadly. So in the case of Indonesia, to the credit of Indonesia, knowing the power and the hold of the Islamic leaders, or at least some, they went through the regulatory and all the safety protocols, but additionally brought in the value dimension and not just the technical assessment and safety control, but went to the Islamic Council for their endorsement also. So I think this was a really important example of bringing together a technical assessment and a value perspective, because people, we see this in the drivers of confidence, are driven by values as much as the technical assessment that we sometimes rely too often on in the scientific and public health community. In the Philippines, as I'm sure everyone knows, and the important work like Karen's and others have played a huge role in rebuilding confidence. But the dengue vaccine saga that created really public panic and a huge politicization of the issue has had a bit of a knock-on effect on COVID-19, but there's also been some issues around the handling of the COVID vaccine introduction. But again, the importance of listening and engagement is really valuable. We've taken our vaccine confidence index work, and as when COVID got going, shifted gears. We didn't drop the ball on listening to vaccine confidence more broadly, but did a special focus on confidence in the COVID vaccine. As you can see here, there are no 2 countries that are exactly the same when it comes to vaccine confidence. It's highly varied, red being the definitely will not take a vaccine, to the darker blue aqua on the right being will take it. The important thing in this slide is that on the right-hand side, as I said, with social media analytics, which give us a different kind of information, they don't give you the kind of information you get from a nationally representative survey, where you have the background demographics of gender, age, education, income, and other factors depending on where you run them. But in this case, we saw above all other of these socioeconomic demographic factors, the factor that had the highest leverage on people's willingness to take a vaccine was government handling of the pandemic. If they felt that it was good, if it was trusted, the willingness and confidence in the vaccine was higher. So it was a predictive factor for positive acceptance. Another thing we've been looking at over time is anyone who's been following the number of surveys we have. This is a highly volatile environment. Already we've seen an increased growing volatility of vaccine sentiment over the last decade. I did an editorial in Science a few weeks ago called The Volatility of Vaccine Confidence. This is not something that you do, you do your textbook perfect vaccine communication and then come back to it the next year. This needs real-time monitoring and engagement because it is as volatile as political opinion polling. This is just a survey from Ipsos Mori, and this is just in 1 month different between December 2020 and the end of January. You can see on the right from one extreme of dropping to some of them dropping, most of them going up, but the amount going up are just from a small 3% to 28%. We have other data of countries who got less confident, but the important thing is the factor of change. As we heard earlier, we have a huge inequity in access to vaccines now. It's a very shattered landscape in terms of where different countries are in the world for many reasons, and this does not breed well for confidence, particularly for those who feel like they're being left out. The World Bank did an analysis of readiness for vaccines. This was published in February, but what was shocking to me, actually, because I thought we had learned a bit about this, less than 30% of 128 countries had any kind of social engagement strategy developed. That's not even saying implemented, that's saying there wasn't even a plan. For more than 70% did not even have a plan. There was a lot more attention to getting the vaccines there in the boxes and getting the regulatory bit approved, identifying the target population, trying to get the safety in place. But the training for those who are deployed, that was the other very low one, was only 30%. And these are brand new vaccines with different factors. This is really a shocking report in the domain of vaccine confidence and acceptance. This was in 2018. It was following there were a lot of discussions. I think it was H1N1 and then the anxieties about some of the other emerging and potential outbreaks we saw. There were a lot of roundtables discussions. Are we ready for the next big one? H1N1 wasn't as bad in 2009 as we had anticipated it could have been, but it did trigger a lot of discussions. Clearly, we didn't follow what we agreed on in many roundtables. But one of the things I was calling out in 2018 was, let's get ready for what I think is one of the biggest pandemic risks was viral misinformation. Sadly, it's been even worse than I expected. Again, I think we have to put this in perspective. We heard in an earlier presentation about the shift in COVID online conversations going more to vaccine and less to the virus. I think that is actually aligns with what the attention and what has been available. This bottom one, this was in the UK. We do regular monitoring of COVID conversations for Public Health England. And in last April, vaccines weren't even in the conversation. And understandably, the focus was on just containing it. We weren't near a vaccine yet. It was still in the labs. but distancing, washing, hand washing, isolation. Now, in August, we started to hear the beginnings of some concerns and discussions about vaccines, the potential vaccines, but still, the lockdown was the biggest anxiety and concern about people and what the impact would be. There was a lot in the background, a lot of denialism that COVID was even exists. Never mind, that it was worth people being locked down. Some of our global leaders were shunning masks that became not a public health measure, but a political symbol, which was not helpful. In Africa, we did a 15-country study collaboratively with Africa CDC. Some of the top 5 concerns there were very consistent with what we're hearing in different parts of the world. I don't trust the vaccine. I don't believe the virus exists. I'm concerned about the safety. I don't feel like I'm at risk. That's particularly if you don't think it exists. And I just don't have enough information. This is one of my favorite pictures. This is not misinformation. This is someone who actually gets that he should protect himself, but he didn't have access to a mask. So I think he should win the 2021 or 2020 award for innovation. This was in Kenya. But these resistance, we can think about liberty and freedom, and there's been a lot of protests against government control, and it's those groups of people who are against government control and intervention more broadly, which is where the vaccine conversations that were historically a bit more separate have totally merged. Any anxieties about government control, government intervention beyond vaccines have now come together in the context of COVID and have been one of the spaces where there's been a huge growth in these resistance groups. But is this just about concepts of liberty and freedom and against government control, or is this also about survival? In India, these protests were not, I want my freedoms as much as I need to feed my family. So we have a lot of these offline issues and movements, but we also have a lot of online, as we've already heard, sentiments. In the UK, in English videos, 1 in 4 YouTube videos were misleading. I get a lot of people asking me questions. Okay, there's a lot of misinformation, but does it actually matter? Does it affect people's decisions? So we did an 8,000 person control trial, 4,000 in the US, 4,000 in the UK. We interviewed them all about their COVID experience, and within that said, would you take a COVID vaccine when it's available? And then we showed 1,000 in each country, positive, factful information, and 3,000, the top 5 circulating pieces of misinformation. We interviewed all of them again more about COVID, and within that inserted a question on, would you take a COVID vaccine? In the UK, there was, in both countries, there was over 6 percentage point drop in willingness to take a vaccine, their confidence in the vaccine. That's not a small amount, particularly when you consider on the left, only 54% in the UK and 41% in the US said they would definitely accept a COVID vaccine. Now, we're talking about herd immunity being somewhere around 70%. I've heard everything from 60 to 80. But when we are barely getting to what would be a herd immunity level, in fact, we're not there, this 6 points matters a lot. And I think that I get a lot of kickback sometimes saying, oh, you're being too negative. And I'm saying this is not, it's mostly access issues. Well, we do have access issues. We've always had access issues. This is different. This is what I would call a tipping point phenomena, in addition to all those other issues that we've always had and will continue to have. This is a new phenomena that needs new modes of intervention and new novel approaches. Just this week, in collaboration with the World Economic Forum, we launched if you just Google how to build trust, WEF, World Economic Forum. We did an analysis collaboratively with a group called Net-Based Quid and the Vaccine Confidence Project and World Economic Forum, trying to get they have a huge reach in their listening, just trying to get a read on what are the sentiments, what are the issues, what are some conclusions and recommendations we can make. I thought this was one of the more beautiful images I've seen, aside from what's written on it, but it's hugely varied. But we came out with 5 key points and recommendations. And one of the fascinating things to me was protection. The word protection was used 5 more times frequently than prevention and 10 times more frequently than stop infection. So what really resonates with people is protection for myself and protection for others. Why does that matter? It's not just an academic exercise. It means that we should be featuring in our communication the term protection because it resonates. Saying things like moral obligation, we found provoke a very strong negative response because it sounds finger wagging. It's saying we're telling you. So even if it's framed as a moral obligation, we saw in the chain of conversations, if that would come in, it got really negative kickback. Messages that are simple, focused on gratitude, coming from health professionals, social influencers, and people like me. I heard one woman said, I'll believe it if it's from someone who looks like me and talks like me. I thought that was the most clear and simple guidance we could have. Lack of trust in the system, concern about side effects and safety were some of the more common drivers, which is also consistent with what we see in our surveys. And there's little difference in the discussions between the types of vaccines, except when it comes to safety. We also see a very strong presence of religious leaders, but we can see positive influencers like, in this case, Bishop Porter. He talks about my COVID vaccine is my shot, and he frames it in terms of what he knows that his following care about. But then on the other hand, we have religious leaders like this one who says that every church is an anti-COVID-19 zone. Don't take the COVID vaccine. So you can't say religious leaders are the ones you should turn to. It depends on the religious leader. It depends on which government leader. It depends on which influencer. Again, we need to constantly be going back and forth and thinking about holistically our response. It's not just about online, it's also offline. We need to think of the bigger ecosystem of information. We see particularly the more anti-vaccine oriented groups are very clever whenever they see restrictions coming on the online. They're jumping offline. They're going into other spaces. And that's where people are. In Africa, for instance, we saw that still TV is the number 1 media influencer, and in West Africa, radio was particularly strong. And in Tanzania, it was another case where it was both the leader of the country who ended up dying of COVID and the following of religious leaders. So praying for a cure and bringing congregations together is a problem. So we have to think about ways to work with different communities depending on their terms. As I mentioned, this is just a reflection that the COVID doesn't exist is not just a Western luxury. It's in some countries that are in the thick of the virus. This is another one, the doubters, the I'll wait and see. This was one of the more poignant cartoons I saw on that issue of waiting. How long will you wait and what's the risk? Just some last few slides on the issue of risk, which we've heard about in a number of contexts this morning, both technical and emotional. And I think we're good as a scientific community when it comes to risk as analysis, but when it comes to risk as feelings, when we come to risk as politics, we are far less prepared. And sometimes there are real risks. As we know, we heard earlier about the blood clots, and there are milder vaccines, but how that was framed and the uncertainty around it had a huge impact. The J&J blood clot announcement in the U.S. got less negative fallout because it happened in a very short period of time. It was called on, it was investigated, and then they moved on. The challenge in Europe is that went back and forth, and there was not agreement, and different countries were doing different things. It had a significant impact in Africa. We had our finger on the pulse in a number of countries, but in Nigeria, for instance, in June 2020, 49% of the representative population said COVID vaccines were confident that COVID vaccines were safe. 47% in June 2020 were confident that the COVID-19 vaccines would be effective. A year later, or just under a year later in March, after this was in the context of the news in Europe about the blood clots, that dropped down to 25% and 24%, almost in half. So that one of that points is the ubiquitousness of this information and how fast it spreads. We have to remember that COVID vaccine alone won't defeat the virus, so that's another challenging thing in terms of risk. How do you communicate that? And we've seen some stumbling on that. We can't forget the broader implications for how how far we've fallen behind in childhood vaccines. So we have to put that in context. And I loved what we heard earlier, and this is one slide, thinking of vaccines as a dose of hope. Some of the positive sentiments building around this was in Bolivia. And one of the positive things we're doing now in terms of trying to build confidence, I should say proactive instead of positive, but it's also positive, finding relatable experts, getting a group of young scientists and doctors, and this is, we call it Team Halo. This is on TikTok, very rapid fire responses to what people are asking. But also you get to know these scientists and doctors outside of the clinic or outside of their lab, doing other things. If you want more stories on this, I recently published a book called Stuck. And actually it was finished before COVID, but the name has turned out to be more relevant than I expected. And this is our website for more. Sorry to go on there, but thanks very much.
Thank you so much, Heidi, for a usual tour de force on this very, very important topic. I think we've all learned from this. I'm going to take a bit of an executive decision here. I think probably if no one is actually falling asleep, we'll do without the 5-minute break that was in the program. This is mainly to allow me to pose the questions that have been coming in. I am very happy to see that Professor Ben Ong is still with us. Basically, I would like to try to pose one question that's come into the Q&A. And I think it's probably best addressed to Professor Ong as chairman of the Singapore Vaccination Strategy Committee. And this is the question. To breed confidence, I suggest the government publicly releases graphical display of data analytics to show the start of all severe adverse events in relation to vaccination date and day of death, again in relation to vaccination date. The government should not only source from adverse events reported directed direct to it, but also sourced from non-official groups that curate such information. So, Ben, would you like to perhaps respond to that question that's been posed?
Sure, Tiki. I think it's an important point that's being raised, but just to put everything in perspective, every single event is actually logged, and every single event is actually investigated before a decision is made one way or the other as to whether or not there's a plausible relationship between an event occurring in relation to a time interval from vaccination to it occurring. I think one has to be very careful to not assume that just because of a timing association is a causation. If we all recall early on when I believe it was Norway rolled out their program and started to vaccinate the elderly population within the nursing homes, there was a sensationalized headline that spoke about deaths occurring. I think one important point to bear in mind is that one needs to know what the prevalent rates in every single sort of causality for death is in your jurisdiction. Work out roughly how often those occur. I think given an assessment, then based on that, there's one metric. But the other is every mortality is usually adjudicated independently. The ministry doesn't look at the cases independently. It's actually adjudicated either by the doctors in the hospital who essentially actually have the interests of the patients at heart, not what we might be trying to do as far as the vaccination program is concerned. And most of them, I would think, are as interested as the committee is and the government is in knowing what the real situation on the ground would turn out to be. As Paul has actually shared earlier, one of the signals that emerged even from the trials was Bell's palsy. And Bell's palsy has also occurred in a local setting, maybe at the upper end of the range that's been reported. But I think as a neurologist, that's the one area that I'm intrigued in as well. Thankfully, as far as I know, all cases have recovered and are quite well now. So I hope that partially address it. Insofar as the information is concerned, if you compare the way we do things to the various websites in the US, various actually takes in all information from every single source, but separately they then look at the relevance of the different information that goes in as well. So one has to be very cautious in terms of interpretation. Thank you.
Thank you very much, Ben, for a very succinct and clear answer. As we know, the issue of adverse reactions was a bit of a concern with Singapore. Ben, I know you have to leave, so thank you for staying on to respond to that. Let me just, the other thing I've noticed is that Professor Tan Eng Chai has stayed with us right through this essentially coming to 4 hours. Professor Tan, if you are still there, would you be interested to ask a question to the panelists? Over to you.
Thank you. I actually have an expert beside me. That's Professor Ben Ong. So I've been asking. Thank you.
Okay. Professor Chong, you have also stayed. Any questions from you before I open it to the broader Q&A? Muted? You're muted.
Sorry, no, I think I'll let the broader audience ask the questions. I think there seems to be so many of them.
Yeah, thank you so much. So yes, I would like to perhaps begin with Heidi. Heidi, there's a question here from Ong Bao Swan, who would like to ask a question. Is public confidence or acceptance of various vaccines influenced by the mode of delivery? Have you any data regarding differences, whether it's oral, intramuscular, or nasal? Obviously, it's not really focused on COVID vaccines, but vaccines more generally, especially since more variety of COVID vaccines might be available in future through different routes of immunization. Would you like to respond to that?
Sure. it's not a major difference that we're seeing, and there haven't been large-scale comparisons that I know, but I can tell you the one that we are familiar with, and well, certainly with polio. I mean, the difference with something like an oral vaccine, as with polio, is that more people, it doesn't need the level of training. And it can, and with a good cold chain, it really, we could get out to some of the remotest areas, and community leaders could give it, and local people. So it does help in terms of access, broader access. But in the case of the nasal vaccine with the around the flu vaccine, we did have some, interestingly, not just the issue of the gelatin being not halal for some Muslim communities, but the other concern they had was, here we thought we'd save the children from a needle injection, but actually the parents were worried it was too close to the brain. So and then you have a whole other well-studied group of people who have needle anxiety. So it's really going to depend on the issue. It is not, I don't think it's as they call it, a deal breaker in itself. It's usually one of the various factors that influence people.
Thank you so much, Heidi. The next question is I thought, a very important one, and something probably I would have wanted to ask myself. So this one I'm going to direct to Ruben, to Scott, and also to Karen. Okay, it's a very short question, but would be very interesting to get your responses. And the question from Grace Wengi is, can we use social media data analysis as a proxy for community or patient perspectives and sentiment? So, Ruben, obviously you've been working in this field for some time, I know. Would you like to have first go at giving your perspective on that question? Go ahead. You're on mute, sorry.
Okay, sorry, I had a double mute. I'm using my phone here. Thank you so much, Tiki, for that question, and thank you, Grace, for that very important question. But my thought as a social scientist always is the importance of triangulation. Because at the end of the day, different techniques will measure vaccine perceptions or confidence really at different levels, right? Surveys, you're measuring directly. You're asking people what do they think. We are measuring behavioral levers and things like that. So that's really individual perceptions. I think for the online media analysis that I described, as well as social media analysis, it is more of societal perspectives. So I don't think, if possible, I think we should really triangulate the data. I don't think we can use one as a proxy for another. So I think for the different techniques, there are strengths and weaknesses. For me, surveys and focus groups would really go deep into some of the thinking process behind it, right? Some of the motivation, some of the thinking process, the nitty-gritty of things. So I think that's survey. For online media, I think it's good because it's long form. It gives us information about content. For social media, because it's rather short form, and social media, there's a gamut of it, right? There's Facebook, there is Twitter, there is now TikTok videos, and so on. But by and large, social media, we have realized that most of the things that are written there are short form. So because of short form, it doesn't quite give us as much of the content as online media does. But it, however, does give us a lot of information about emotions. So the other part, the other project that I'm working on is really looking at emotions towards vaccine hesitancy, the content of emotions for vaccine hesitancy in social media. Because sometimes people are hesitant about the vaccine because of mistrust, sometimes it could be anger. So what I'm proposing here is that if we can fuse together surveys, content of vaccine hesitancy from online media and emotions from social media, I think we can take a very targeted approach to decrease hesitancy, such as what are the emotions, what is the content, and we try to get an intervention to decrease it. I just wanted to say something very quickly also, sometimes we always think about communicating directly. So, for example, maybe older adults, they have some vaccine hesitancy. Let's communicate with them directly. Now, sometimes actually there are indirect ways of communicating. One of the ways to communicate with older adults could be through their grandchildren or their kids, right? So if we communicate indirectly, we need to use different medium, whether it's TikTok to get from children to parents. So we need a sort of a layered and differentiated strategy to decrease vaccine hesitancy, and we shouldn't be thinking only of direct and linear strategies.
Thank you, Ruben. Scott, what are your views on using social media analysis as a proxy for community sentiments and views?
Yeah, thanks, Prof. Tiki. So I actually agree with a lot of Dr. Ruben's points. And actually, in the height of the COVID vaccine rollout in January, we actually saw, not only social media, but a lot of people were talking about whether they should vaccinate their parents as caregivers as well. And we actually, even in our own surveys, we were actually able to reach out to several people and say, hey, would you actually like to bring your grandmother to come down? Does your grandmother even think about DNA or RNA and things like that? And so those were the ways we were actually trying to do so and allow me to explain it better as a medical doctor. But I think this question is something that will evolve over time. So TikTok may be the one that's more famous today, just like how YouTube was more famous like 10 years ago. And maybe even 6 months later, things will change. Like if we look at TikTok, it's only mostly in the age about the 20s and the 30s and 15-second videos. Whereas maybe the generation 10 years ago, people still use more Facebook for the 40s and 50s. So I think it should be viewed as supplementary. Every weapon that we can use, we should use it. But we also need to contextualize the image. And there are still, no ways to replace coffee shop talk. Going down and see the old uncles in our own hawker centers and saying, hey, what do you think of the vaccines? There's still no substitute for that. So we have to think of everything as a whole, as a cohesive strategy.
Thank you very much, Scott. Karen, what's your perspective from the community, from the patients? And I think Scott and Ruben also highlighted what you mentioned was the importance of who the messengers are. So over to you.
Yes, thank you. And I agree with both of them that social listening is just one of the tools that we can use to measure engagement. But certainly it's not the end all and be all, because we have to remember that in many parts of the world, there's still a digital divide. For instance, in my country, there's a high cost of internet connectivity. So we're not reaching marginalized communities. We're not reaching our senior citizens. So it's important that we use several platforms, both offline and online. And I think we shouldn't also discount talking with, as mentioned, the coffee shops, but here in the Philippines, we call them barangays. So talking to people in the community stores, people in the motorcycles, I think you'll be able to get a lot of insights, and having regular platforms to be able to reach these audiences is very, very important.
Thank you so much. The next question, I'm probably going to address this to Heidi, and it's something that I've been sort of anecdotally seeing on the many news channels that I follow. And this is around the question of, are financial incentives an effective intervention to reduce vaccine hesitancy? I've seen examples of people offering free donuts, free airline tickets, free lottery tickets, even cash for people to get vaccinated. So Heidi, what's your view on this? Is it something that's going to be useful to reduce hesitancy?
I've even seen that I was told that there's even sections on dating apps that you're in a special category if you're vaccinated. I think You know, you've got to give people credit for trying to come up with some clever incentives, but I don't. It's not going to fix it for everyone. I mean, I think if people are generally thinking about they are going to take it, but they want to wait and see, or they're almost there, but they're still a bit on the fence, that might be enough to motivate them. But it's definitely not someone with anything more than a temporary hesitation. And we do have data now that it might get someone for their first one, but don't count on them coming back for their second.
Okay, thank you for that. Karen, would you, from a patient or from a community perspective, would incentives, in your view, based on your work with the patient organizations, would that be something that would appeal to a lot of people?
I'm not sure. We're still early days in terms of trying it in the Philippines. Actually, the corporate sector has come up with a proposal. I think for some people it can work, and they'll be happy to take on the additional incentive. But for many people, it may not, because the fears and the anxieties are coming from somewhere else. And it's not enough that you incentivize them, especially if they don't need incentives such as this, right? So it may work, and it's good to try all the means. And certainly many countries are trying it. But it would be interesting to see whether it really works in real life.
Okay, thank you very much. Wow, we're getting lots and lots of very interesting questions here. So the next one, it's probably going to be directed towards Ruben and Scott. See whether you're comfortable about addressing this one. The Singapore vaccination strategy has basically an intention of vaccinating the whole population at large. I'm not sure if there is any evidence available to guide this. Working from first principles, what is the risk reduction we are hoping to achieve by vaccinating the young, healthy population? Ruben, is that something you want to try and address with your background in risk reduction?
To be honest, I'm no expert in risk reduction. I'm more the risk communication part.
Okay.
But I think, I don't know, a quick thought is, I think right now, because of the new variants, there are particular populations who I think are more vulnerable. I have 3 young kids. They're very young. They go to preschool. So I think a vaccination strategy would further sort of reduce the risk really for certain groups that we previously have not thought about. So I'm sort of thinking from more a risk reduction for different cohort perspective. Okay. And I think if we increase that vaccination, it will decrease the risk for certain groups that we thought were not of a high risk group.
Okay, thank you, Scott. Anything to add to that?
I just think that the definitions of young, whether it's kids or whether it's like working population, and also what is the whether the risk reduction is to the person or is actually to the people surrounding that person is also part of the question. And I kind of think that the ultimate ideal situation is that we vaccinate like almost everybody. And the way that Singapore roll out is like, regardless of whether you're young or the risk, we're just going to try and roll it out as fast as possible. And particularly, it's actually not about the age as well. It's about even the risk of the occupation and like frontline workers. I'm already vaccinated since February. So there are many facets to it, but I think in the current time with the outbreak, it's quite crucial that we relook the strategy, particularly for those from the 12 to 17 age group. And all this, I'm not qualified to say, and perhaps someone who's more scientific can answer that. Yeah.
Okay, thank you, Scott. Heidi, what are your views on this? I was reflecting on my own home country of Indonesia, where, about when they first started the rollout, they had a very unusual policy decision, to focus on what they call, let us vaccinate the most productive sector of society. And they were targeting sort of young workers, the age group between 20 and 45. And then the situation developed, and now they've done a big turnaround to sort of say, okay, we're going to change it now to the elderly. And, so each country seems to be, flip-flopping. What are your views on this in terms of, what are the optimal choices for covering, segments of the population?
Well, it partly depends on your demographics, but I think in the case of Indonesia, on the one hand, they were saying to focus on the more productive part of the population, but they were also concerned that some of the early trials did not include people over 60 or 65, I think it was. And they were quite explicit about that in some meetings, that the rationale for this was because they didn't have enough evidence of the safety and effectiveness in the elderly. I think that, in the meanwhile, there's been a lot more information out there, a lot more data. And I think part of the reasons that countries have been shifting their focus is with the new evidence. So I think some of it is just chaos, but I think we do need a little bit of empathy with the environment, the decision-making environment that we're in, that is constantly changing. And it's certainly, for instance, in Europe, some countries like Germany also started with a younger group and started seeing some of these risks in younger ages than before the UK did. But that's because we started with the super elderly, as some call, So I think that, more harmony would be helpful if you want to build public confidence. But at the same time, I think people are trying to deal with, the information they have. I'm sorry that wasn't a simple answer, but hasn't been a simple context to be making.
Obviously, it's so dependent on each country's context, each country's burden, each country's capabilities, each country's resources. Quick follow-up for you, Heidi, because I know you're an anthropologist. Okay, so there's a question here. Correct me if I'm wrong, but some anthropologists appeal to remote indigenous communities by offering food, medicine, or vaccines for exchange of acceptance to participate in research. Is this a form of incentivization? You're on mute, sorry.
Oh, sorry. I wouldn't say this is unique to anthropologists. I mean, I think in trials and other kinds of research, you want to give people, you want to be supportive and in the community and be responsive to other people's needs. You're taking their time. You want to compensate them. I think there's always this kind of borderline anxiety that can feel like manipulation, but it's certainly not the intention. You do want cooperation, but I think if people don't want to cooperate, as I mentioned with the earlier question about incentives, that little extra may not make a difference, but it may help. It's a gesture, but to be fair, it's not just anthropologists. Research in general, you want to be kind of giving with the community that is sharing a lot of information and whatever.
Absolutely. Okay, Karen, this is a question for you. Dr. Karen has hit the nail on the head. For a procedure as important as vaccination, affecting not only adults, but also children, which becomes a very emotional issue, obviously, listening to the people's concerns are very important, and not to just thump them down very forcefully, which generates even more resentment as far as I have observed. Can you please comment on that?
Thanks. Professor Tiki, I just wanted to make a comment on the incentives.
Oh, sure. Please go ahead.
Because with respect to clinical research and patients participating, it's not really an incentive. Rather, it's given to provide, for example, transportation money and meals, for instance. So under the ethical framework of clinical research, patients are not supposed to be compensated and incentivized. So just wanted to clarify that. And on the question on thumping people, yes, sure, it may work for some people, but not for everyone. And I think people have access to so much information that they feel that they know they have the capability or the capacity to be able to think for themselves. So that's exactly the reason why in the campaign that we want to do for the Philippines in terms of increasing vaccine acceptance, we wanted to take a different approach because we wanted to stop, the fear. We wanted to stop the imposition of, because we're the medical experts, we know better. We want to listen and we want to connect, right, with the everyday person, with the things, even the language that the normal people use. We need to be able to use that to reach them. And hopefully this campaign that we're going to launch will be something that will resonate. That's very important. Thank you.
Thank you. I mean, at that point about reaching them, it reminded me actually of a study that Heidi actually shared with me about the role of celebrities as messengers. This was a survey done in Indonesia. And the very interesting finding was that celebrities had a lot of impact in sending a message, but only when they spoke in their own voice, rather than saying, Professor so-and-so said this, the health minister said this. When they spoke in their own voice, the impact of their sending the message was much more than if they were just parroting official lines or so-called experts. So just something that I remembered when you were talking about reaching them. Okay, the next question is back to Ruben and to Scott. Okay, so Ruben, the question is, may I know which tools you use to gauge the sentiments in your studies?
Sure. Thank you, Tiki, for that question. I just wanted to, before I answer the question, I wanted to echo what you said, that it's really important to speak the language of the people you're speaking to, right? Because I always feel that if you don't speak the language of the people you're helping, you're quite helpless. So sometimes, on one hand, you want celebrities to speak their own language instead of parroting the official line. We also want to speak directly to some people. So, for example, some of the older adults in Singapore, as you know, they are very heterogeneous. They don't all speak Mandarin. They don't all speak English. Perhaps we need a more dialect campaign, from Teochew to Tamil, so that you speak directly to them. Of course, via their grandchildren as well. So that's just one quick point. So about the question of what tools we use to measure sentiment. So to be honest, I'm quite a lazy guy. So if I can get something off the shelf, I would. But in terms of sentiments, I haven't found things off the shelf that I could use. There are sort of two types of sentiment engines out there. One is they would rate sentiments based on binary, whether it's positive or negative. But that doesn't quite work for us because we need intensity. That's why we have sort of looked at 1 to 5. Okay, so a lot of binary stuff out there doesn't quite work for us. The other kind of sentiment engines out there, it's a very long range. So from -10 to +10, for example. But then their sentiment library only has 50,000 words or 10,000 words. But for us, we are looking at 100,000, 200,000 descriptors of vaccines. So those didn't quite work for us. That's why we started building our own sentiment engine. The sentiment engine that we built consists of words that are checked for context, as well as rated by 2 persons for inter-rater reliability. So we have sort of built our own sentiment engine. The other thing I wanted to quickly say is some of these AI products out there, sometimes when they compile the collocates or descriptors of vaccines or different topics, aren't quite accurate, to be quite honest with you. So, for example, I'll just give you three examples why we need to write our own algorithms. So a couple of years ago, I was doing some work for the National Institute of Aging in the US. They were asking me to look at, can you tell me, Ruben, what are the narratives and sentiments towards older adults over the past 200 years? So I realized that one of the nouns referring to an older person is aged. But aged, could refer to goats or cheese, not so relevant to older people, right? So we need that context. Then I was doing something recently also about the narrative towards jobs and skills. And we found that using AI tools out there, there's some exuberance towards jobs. And I realized that it's actually Steve Jobs and not jobs. So that's why I found the need, to because of accuracy, to write some of these. The other thing very quickly is falls, right? Singapore is actually has a very high community fall rate. So to change the behaviors about people falling down about falls, we need to look at perceptions. So falls is actually the most difficult I've looked at, because falls could refer to Niagara Falls. It could refer to people falling down, right? It could refer to fall semester, autumn time. So because all these AI tools out there take this as a margin of error, but I can't. As a social scientist advising the government, I need to be as accurate as possible. So because of that, we have found the need to write our own algorithms, work with linguists to make sure we pass out the signals from the noise.
Okay, thank you, Ruben. Scott, obviously you've put a lot of thought, you have a lot of knowledge about all the digital health tools that are out there, and obviously you've thought a lot about how it applied in your own work. So would you like to elaborate on which sort of tools that you have been using and perhaps the pros and cons?
Yeah, actually I'm even lazier than Ruben, so I kind of see what some people do, but I have the benefit of also talking to many patients in my daily practice. So what I do is I kind of no matter what tool I use, whether it be like Facebook or even like when I saw like Ruben's work 2 months ago, I just go back to my 50 patients a day and just directly ask them, do you, what do you think of this vaccination? And what I often do is I like to create a feedback loop where you just call the people on the ground to see whether these insights actually work. Then it's a combination. So I kind of use a combination like what Ruben does, and I just use my own clinical practice to find a middle ground that I can act on, at least in the local context.
Okay, thank you. That's a thoughtful answer. Heidi, I'm going back to you. This is like the $64 question here. And the question is there a possibility for a universal vaccine approval process? Does the difference of acceptance for vaccine use in different countries impact vaccine confidence? Around universal vaccine approval.
Approval meaning a regulatory approval?
I think so, yes. I think that's what they're getting at. Because a lot of countries, especially developing countries, they look at the US FDA. And if they sort of see that US FDA has approved, it's sort of accepted in the country. So what's your view? Is that likely to be possible?
Well, there is, WHO does have an approval process for particularly for any vaccines procured through the UN, need to go through their pre-approval process. But that's not as rigorous as an FDA. Right. But it's probably in terms of a cross-country evaluation, as it were. That's probably closer. FDA people do look at it. It is pretty rigorous. If FDA passes it, but it is varied, and it's true. I think the most kind of cross country, but at the end of the day, it really depends on the national regulatory authority. People don't want to use a vaccine just because another country approved it. They want their own approval.
No, obviously there's an element of that sort of nationalism there, but I do know that in the context of ASEAN, there is something called the ASEAN Preparedness and Response Framework, And one of the recommendations is for some kind of exploration of regulatory harmonization amongst the ASEAN member states. I know that's something that Singapore is also very closely involved in. So I think things might be happening at the regional level, and reflecting back on my years at WHO in terms of medicines approval more generally, there was a similar move in Africa to have a sort of a pan-African harmonization process. Okay, sorry, Heidi, another one for you. Professor Larsen, in the context of Indonesia, since you are familiar with it, I know, most families are intergenerational. So the working population, the young, were at greatest risk of bringing it back to their elders who stay at home. That was their official rationale for focusing on the working population. What's your view on this?
Yes, it was also another factor, but my point earlier was that wasn't the only factor. I mean, there were a mix of considerations, as there should be, and I think that was a reasonable approach. I mean, we know there's plenty of data, for instance, on pneumonia, that if children are vaccinated, that the burden of disease in the elderly population goes down. So particularly with respiratory illnesses, I think that was a totally reasonable thing for them to consider.
Okay. Yeah, thank you for that. Yeah, that I believe was also the thinking behind the government policy. But of course, what they're facing now is quite an acute shortage in supply, as well as the logistic challenges, in addition to the hesitancy. Okay, the next question is actually from me. Okay, I've been meaning to ask this to Karen, actually. I think you made a very important point about patients, consumers, maybe even the community, to be involved in every stage of the vaccine development process. But I've always thought about this as being perhaps aspirational, in the sense that when you are faced with the pressure of a huge pandemic, and there is a very urgent need to come up with a product quickly because of the sheer scale of the pandemic, what is more important, speed to develop the product or inclusiveness in the process? How do you balance that? I mean, how do you sort of make sure that the patients and the public and the consumers are engaged right from the beginning, when there's so much pressure from the global community, in this case, to get these vaccines out quickly, sort of saying, is it market driven, or is it a case of social inclusion, of consulting anyone who might be affected? Any views on that?
So I think this is where the institutionalization of patient participation in health policy making is very critical, because if we're already part of the process, then there's really no need to call everybody, right? Because naturally within the process, there's already the patient voice, right? And it's, if other countries or regions can do that in EU and the UK, then certainly for Asia Pacific, Africa, South America, there's also hope that one day that will happen. And that's precisely the reason why we're advocating for inclusion, and not just inclusion when there's time or where speed is not an issue, but really being embedded in the process, so to speak.
Okay, thank you very much. And just a follow-up question: how would you ensure that actually happens in terms of the policy making process?
Well, for one, I think, and this is one of the things we're trying to do, is we're building our own capacity. For instance, we're building our own skills, so that when we're part of the discussion, we also come up with solutions and We also try to be evidence-based. So we try to capacitate ourselves and to reach that level where our voice becomes relevant, and not just relevant, but helpful. And that's where the co-creation part comes in. Because unless we build those skills, then we'll always be seen as, oh, you're just coming with a bunch of asks and problems and issues, but you're not really providing solutions. So we want to correct that. And one way of doing that is really upskilling ourselves. And this is where, you know, we're constantly appreciative of our partners, other stakeholders, because we learn from them and we learn from each other. And, you know, getting invited is one big step already. So we want to come prepared and useful.
Thank you very much. I love that term, co-creation. Wonderful. Heidi, back to you with another $64 question. Hello, Professor Larson. With regard to vaccine passports, will a vaccine passport issued by one country be accepted by every single country in the world? What may be the role for the WHO in case country A uses a COVID vaccine that is not being approved by regulatory authorities in country B? Will the vaccine passport carried by citizens of country A while traveling be honored in country B? Over to you.
You're asking all the questions that people are thinking about right now.
Exactly.
I think there is, I know certainly across Europe, but efforts to do a kind of harmonized app, digital way to read this. And I do know that there are countries that only, you know, approve certain vaccines. How much that can be kind of considered in whatever app. We're not there yet with anything that's globally coherent. Mm-hmm. I think, you know, already if we can get into some regional coherence, it's already a leap. But the whole issue of vaccine passports has been very interesting. I mean, I've, since before I can remember, almost have carried this yellow dog-eared WHO vaccination card, where I always had it stamped, because some countries need, for instance, yellow fever. To go to Hajj, you need 3 other vaccines, and it's probably going to add COVID. So I think that, but in principle, the digital one will be more easy. But on the other hand, sometimes I think people are as anxious about the notion of it being digital as, you know, much as the passport. And some of the recent research we've shown is that for people who are pro-vaccine, they don't have a problem with passports. For those who are hesitant, the idea of a passport being needed makes them more hesitant.
Yeah, I think that's an important point. And there's this lack of coherence. I think it will sort of take time to sort of resolve itself. Let me share a personal story. My wife got her 2 doses in Geneva of the vaccine. Somehow she got hold of this yellow book WHO used to issue. She went to the vaccination center, said to them, "Can you put my 2 vaccines in this book?" Immediately they said, "Yes, put the 2 shots there. I have been given the 2 COVID vaccines." She then sent me the book and said, "You go to the Singapore vaccination center and get the chop in this book." So I went to the vaccination center. They looked at it and said, "What is this? We're not going to sign this. We don't even have authority to sign something like that." So obviously, you know, different countries are going to sort of treat this issue differently. Okay, perhaps we have just maybe 2 final questions, and this comes, unfortunately, there's no name here, the questioner here. Dr. Ruben and Dr. Scott Wong, you have highlighted very interesting, innovative approaches to analyze confidence, to improve I'm trying to paraphrase it. You've used innovative approaches to look at trends, to improve confidence in migrant workers. A lot of these studies that you are describing is analytical rather than being empirical research. How do you foresee transmitting this to policymakers? I think related to what Karen said before, you can embed this, but how do you actually get it to the policymakers? Ruben, any response to that?
That's a great question. I kind of like to think of it as a value chain approach. What we do on vaccine narratives may or may not be directly relevant. You need to sort of value add it for policy making. So I think from a policy making perspective, how do we increase vaccination rates? I usually talk about 4 typical approaches. One is the lawyer approach, right? Let's legislate it. The other one is the economics approach. Can we have an incentive or disincentive? The third could be a marketing approach. Could we appeal to emotions of people, like what Heidi mentioned, frame it as a protection narrative? The other one are what nudges we can put in place. So I think what I'm doing really leads to how perhaps to create nudges, how to frame the message. So for example, just leveraging on what Heidi mentioned in some of her analysis, if we frame it more as a protective agenda, protective agenda, that may communicate better and nudge people towards actually getting their vaccines. So at the end of the day, I think best practices may not be best for every group. I think we need to take a differentiated approach to see how best to frame the messages, what are the channels of communication, because ultimately these are micro-tactical approach that will really achieve our last mile goals, which is getting people vaccinated for the 2 jabs.
Scott, any responses? How would you get your findings amongst the migrant workers over to the Ministry of Manpower?
Actually, it's already being done live as we are speaking. So a lot of the stuff that we created, all this technology actually is being deployed as we speak not for vaccinations, but now for rapid self-testing on the ground as we speak, directly from the Ministry of Health and Ministry of Manpower. So the idea that we are able to create these solutions that work in very low internet, low resource things and were already custom for migrant workers meant that we are able to develop, test, pilot, and even deploy in less than 7 days now. So the idea that I think in the reality, when there is a need, then there is actually nothing that prevents policymakers from directly going to the ground with all the technology and doing what's necessary. So that's actually happening right now.
Thank you very much. Okay, we are nearly out of time. What I'm going to do is perhaps ask each of you if you would like to make just a final statement or final comment before we wrap this up, okay? Just reflections, if you like. Let me start with Heidi. One key message.
One key message is we need to put our vaccine communication in the context of COVID recovery. Remember that people have other concerns besides the vaccine and try to make this part of the effort towards COVID recovery.
Excellent. Recovery. Karen, some last words, thoughts from you.
So I think I'll choose the word co-creation.
Yes.
And I'd really like to see the day when many stakeholders come together and not forgetting the voice of the patient. I saw so many comments about affirming that medicines are really for people. Medicines and vaccines are for people, and therefore including the people's voice is very important so that we can successfully overcome the pandemic. And I think post-pandemic, we're going to see a lot of self-care and home care. And I hope that with the digital tools that we have and the fact that people are starting to embrace virtual care, that this will continue to be a service delivery option open to patients. Thank you.
Ruben, any last thoughts from you?
Sure. Tiki and Heidi, I just wanted to congratulate you on organizing this particular session, and Tiki especially for moderating this so well. It made me think so much and learn so much. So I have just 2 quick points I wanted to mention. I think the first is we probably need to take a whole of government approach to vaccination, because currently the approach really, the lead agency really is the Ministry of Health. But maybe we need to start to think about, from the Ministry of Family and Social Development, even Ministry of Transport, how can we take a whole of government approach towards vaccination? I think that will push things ahead, that will accelerate things. The other thought I have is I'm actually very concerned about some of the developing countries who are very slow in the vaccination process. And I'm also very concerned that there may be a lack of vials and needles for our vaccines moving forward, because we might need to take it every 6 months. So I think it's time we really consider, especially for developing countries who are sort of late in the queue, to think about whether there are other ways of vaccinating their population, such as nasal sprays or oral vaccinations. I think we need to think about these things so that we can ramp up the vaccination rates.
Very good. Whole of government approach. Very important. Scott, some final reflections from you?
Yeah, I think really agree with all the statements, and I think that health is more than healthcare, and we are not just talking about the usual patients, but talking about people. So we really understand all the needs of the people, and of which we can contextualize, vaccine hesitancy as one of them. Then we can really surround the stakeholders and the technology to solve what the problem is at the moment. Yeah.
Thank you, Scott. Last but not least, the wise man in the room is Professor Chong. Yap Seng, you want to give us some final reflections on, and thank you for staying the whole day today.
Thanks, Tiki. Well, first thing I want to congratulate you and Heidi and all the panelists for for a wonderful session, and thank you so much for all your efforts. For me, I think COVID-19 in this pandemic is a defining moment in history and for humankind, and we should really take all the lessons we learn from this and all the twists and turns to really think carefully about how we should proceed with in the way we do things. So and it's important that if and when the pandemic recedes, that we don't just go back to business as usual, because we really need to learn from this episode.
Thank you, Yap Seng. Why? Any last minute reflections?
Not at all. I think we have had a very, very educational session, and thanks so much to all the panelists for participating and educating all of us on this. Over back to you, Tiki.
Well, thank you so much. We are, I think, actually right on time. I just want to sort of once again express my thanks to everybody. I learned so much from all of you today. Just 2 words of gratitude, especially, first of all, to the institute within NUS that's hosting the coalition, the Behavioral and Implementation Interventions Institute, which is called BC. I would like to thank BC and Robin Milden for the support that they've given to APIC. And finally, to the MedX team, who has been really absolutely wonderful in taking care of the technology today to make sure that everything went seamless. So thank you, MedX. Thank you, BC. Thank you, all of you. Have a good evening, morning, afternoon, whatever. Thank you. Bye-bye.